Afternoon, Prof.
Hi, good afternoon. How are you, Amina?
I'm very well, Prof. How are you?
I'm all right, thanks. I'm all right.
How was the shopping trip yesterday?
Afternoon, Prof. Day before, yeah, it was good. It was good. We had done online ordering, so I didn't have to go into the shop. Hi, good afternoon. How are you, Amina?
I'm very well, Prof. How are you?
Sorry, this is the YouTube coming on. Just 1 minute. Let me switch off the YouTube. Sorry, that was the YouTube live. It's always a time lag on it.
That is no problem. No problem, Prof.
All right, I'm going to just 20 minutes more. So I'll just open the door for everybody who wants to come in, and then we'll start in 20 minutes.
Okay, all right. So this means it's a time for Asr prayer 5 minutes before joining.
That's exactly what I want to do, actually.
Exactly. Okay. Thank you, Prof. Thank you.
Very nice.
Thank you.
Hi, sir. Assalamu alaikum. Hope you're fine. Nice to see you, sir.
Walaikum salam. How are you?
This is Dr. Faizul from Dhaka. Yes, sir.
Hey, Dr. Faizul.
I don't like to miss your
Soon
lectures.
make you into a thoracic surgeon, huh?
Yes, I don't like to miss anything, you know. It's better to remain sunk in the ocean of knowledge than to be lost in the corona.
Very good, very good. I'm very happy to see you.
Yes, I'm not missing any lecture from my ICTS, attending all the classes.
Just for information of everybody else, Dr. Faizul is a senior pediatric cardiac surgeon from Dhaka, doing some really, really good work.
Thank you very much, sir, for your
He's
gesture.
so humble that he comes to our meetings to listen to thoracic surgery. He doesn't need to listen to thoracic surgery, but
I love to teach my students whenever I get any chance to talk on,
excellent, Dr. Faizul. Excellent. I'm very, very impressed. Well done.
Sometimes we were saying that once upon a time we were saying knowledge is power, then came information is power. Now it is said connectivity is power.
Yes.
And so ICT has made all things together to make us more powerful.
Yeah, good. I'm very pleased. Very pleased. Are you sharing this link with your Bangladesh thoracic surgeons or not?
I talked to Shakil Bhai to get in touch. Later on I'll give them the links. I said, but sometimes they don't get time. But I said, let them not miss the things.
You must.
Today there was a lecture on transesophageal echo by Dr. Thorab, and another lecture was on pulmonary hypertension by Dr. Parvati Iyer madam was there.
Did you enjoy it?
Yes, I enjoyed it.
Very good, very good. I'm very pleased.
Thank you,
This
sir.
is the most basic lecture, actually. It's something
Exactly, sir.
which a lot of people need to understand. So
yes, sir.
I'm trying to get some basic message across.
I'm not very smart in, doing works in to computer and all these things. My daughter is helping me all out to get it.
You are very smart in treating patients. That is the most important thing.
I do try, and I do feel that I'm made for. Today I had an operation because the patient was having B negative blood, so I couldn't operate. They couldn't manage, so I had to postpone. And I got time to, otherwise I would feel sorry to miss your lecture. So I got time, and I'm happy to see you.
Oh, you're doing an amazing contribution to the healthcare of Bangladesh.
Sir.
As you know, I love coming to Dhaka.
Okay, we are looking forward. Yes, so let us feel that sometimes all the path from across the world becomes free of corona, and the fear goes, and let us be free again. Like the birds are not bound by the corona fright, but we like to be barred.
That is true. That is very correct. Very correct.
So it is said that the Allah has made the upper world free of Iblis, not the ground, as the Quranic verses is said.
It is a very.
It is a time to. I found that, sir, it is a time to work on every individual's own quality development and human quality development, so that we all, get rid of all the sufferings and all these things.
Absolutely correct. Absolutely correct. Very, very, very important. It's a good insight into where we are heading.
Right.
Some very close friends have actually, unfortunately, died. Cardiac surgeons in London who are in UK, not London.
Right. He was working in Cardiff.
Very, very shocking. Very shocking.
Right. Very, very shocking. I shared it among our cardiac surgeons, fraternity, and to convey their, all-out prayers for his, departed soul.
Yeah. Also, his family is in difficult times.
Right, sir. Possibly Dr. Shahbaz Khan from Saudi Arabia, he came and joined to that hospital. He was working in pediatric cardiac surgery in Escorts, Fortis, while I was in Escort in 2013. And now he joined in Cardiff, possibly with him, and they are from the same hospital.
I know Indu Deglukar is the chairman of that hospital.
I see.
Cardiac unit. She's an Indian. She's my contemporary, and she's heading the cardiothoracic unit in Cardiff, Wales. And this guy used to work with her. It's a shame. Indu Deglukar is from India, actually, from South India, and she's doing very well in the UK.
And through you, I like to convey my best regards to all the participants and all the. I'm so happy to see all the, you see, the participant, the residents. They're so much, benefited by this arrangement done by this ISCTS. It's a great contribution. I send my note of thanks to ISCTS through the Dr. Hiramat to convey my regards. And this is a huge work for the future light bearers of the subject.
That is the whole idea. You see, that's why we are doing what we're doing, so that
That's it.
when we are not there, these guys will carry the torch.
Exactly. This is the future light bearers, I said.
Absolutely right. So that's. I hope that all these talks, these recordings will stay there and remind them of you and me when we are gone.
Thank you, sir.
10 more minutes. I was trying to catch up on my lunch quickly. I was busy today in the garden. We were out in my backyard. I have a decent.
My sister in Sydney. She is having some sort of fever and sneeze. We were worried about, so we are all praying for her so that she doesn't catch of that.
It's a real worry. I hope everything goes well.
My daughter is in Kuala Lumpur. Elder daughter.
She? Oh, I see.
My elder daughter.
Is everything okay in Kuala Lumpur?
She's doing fine, and she is very smart. She doesn't like to hear all this news. She's just reading and attending online classes.
Oh, I see. Is she a doctor?
No, sir. She is studying computer science and engineering in Help University, Kuala Lumpur.
Very sensible not to be a doctor.
She got. She was selected for general entrance in medical science in Bangladesh, but she didn't pursue.
Oh, I see.
But we would be happy if she would pursue.
So is Bangladesh under lockdown or is it still...
Absolutely locked. It has been extended up to 24th of April. First it was up to 4th, then extended to 14th. Now it's up to 24th. But you cannot control. But now it has been, because the number of cases are now increasing, so people are taking care. But it's the economic issues are there. There are some. It's not possible to run the country without. So someday we hope it will be in ease.
I know it's because there's a lot of poverty.
Today there was a message from WHO that the WHO director, he said, whatever the power of the country, whatever the high quality of the medical development is there, but Corona has to be managed by every individual.
Of course.
It means it's a message. Every individual should work on his or herself.
Yeah, that is true. That is true. It's a very difficult time actually, but this is a good technology. At least we are able to reach out to everybody, and I don't feel as if we are isolated. To be honest, last couple of weeks in India, because I travel so much, I had to almost take a back step. I couldn't, because I had just come back from international travel when all this happened. So I had to take isolation measures, but it has been very good because at least it gave me an opportunity to read and teach these young people. Particularly for my PG student, Nikhil Rane, I want him to, he's got a study buddy. I'm his study buddy. I am all these people who are going exam going, I'm their study buddy. So I'm reading more than they are, I'm pretty certain.
Yes, sir. You are reading more than us.
I'll tell you, my wife is complaining. She's saying, you're more busy now than you were before.
Right.
But we just have to do what we have to do. So what's the time?
Thank you, sir.
Thank you, sir.
Who's that? That's Nikhil. That's Nikhil, okay? This is all for Nikhil. He
Yes,
cannot
sir.
complain that I didn't teach him.
No, sir, you are teaching me very well.
Every single topic in the textbook will be covered now. You have no excuse.
Yes, sir.
So I'm your official study buddy.
Thank you, sir.
Okay, good. So good to know that you're locked down. That's important. Okay, how are we doing with time? We've still got 4 or 5 minutes left, so let's just.
It's a few people.
I'm going to just switch off my microphone. I want to finish my lunch. I've literally just got a chance, so let me just have a couple of minutes to eat something, and then I'll join you guys. Okay? 5 o'clock sharp. I'll be there. Is that okay?
Certainly, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yeah. Stay online. Give me a few minutes. I'll just quickly catch up. Now, how do I catch up on this thing? Shilpa, you're very amused, huh?
Yes.
I have to eat something, man.
I always wait for your last words whenever some chaos is happening in the group. Yeah. Yes. Okay. Oh. I'm also struggling with things. No, like suture, never there.
Akram sir. Yes, he's from Bangladesh also.
Good evening.
Yes, Assalamu alaikum, Dr. Akram.
Yeah.
Nice to see you, sir.
Hi, Faiz. How are you?
Yes, I'm attending class of Ali Jamir sir for the couple of days. It's nice to see you. He was asking me, any of from Bangladeshi, attending. I'm happy to see you. I said to Dr. Shakil Bhai so that he attends and he also to others.
I attended just 2 classes, but due to internal problem, I can't show myself. I can hear only, and
Yes.
I'm seeing on YouTube only, but rather I can't show myself. I can't question even.
Hope you are, in good health and spirit.
Yeah, definitely.
Hi, Dr. Akramal. How are you?
Yes, Akram bhai.
Yeah. How are you?
Assalamu alaikum.
Walaikum salam.
Just for everybody's information, Dr. Akramal is one of the senior surgeons, thoracic surgeons
Thoracic surgeon.
from Dhaka,
Senior?
Bangladesh.
A bearded senior surgeon.
Well, I can tell you, I have visited his hospital. He's the director of that hospital. 50 of them got together, put in an investment, and started a hospital in Dhaka. And I'll tell you, it's one of the most. I mean, you cannot find a better international center than his hospital.
And with this correction, I like to inform that I'm the attendee of first VATS workshop in Bangladesh under your guidance. And I can recall,
I remember that.
I was
Definitely.
the pericardium.
Dr. Khan was there to done a VATS lobectomy of one of the director's son. Yeah, do you remember? He's absolutely okay. He's in Australia.
Yes. Very pleased.
Yeah,
that was a complex case.
Rather in
wasn't
COVID condition, we are suspending all the routine cases except lung cancers, esophageal cancers. I've done 2 fluoroscopies today.
Okay.
It was true sense. It was a life saving, rather huge massive diffusion with no clue at all. I have seen a lot of mats in the pleural surfaces. So, I've done.
You see, sir, Dr. Akram and I myself both are wearing masks even at home.
Yeah.
We are truly in practice.
Oh, very good.
Yeah.
Good, but I have to say, you guys are doing some good work in Dhaka. I mean, the conditions in the government hospital are not so good, but you guys are really doing amazing stuff.
Yeah.
Also, the interventional pulmonology as well. Dr. Zakir is doing all these complex procedures in NIDCH. I mean, it's just amazing. So anybody who's complaining about what you've got in your hospital, stop complaining. You've got to see what is the quality of work that these guys do. I mean, it's just mind-boggling.
Yeah, definitely. We are under one roof. We have all the facilities like Chota Medanta.
Yeah, definitely. No doubt about it. For sure, the Bangladesh International Super Speciality Hospital
has got a similar feel to
And
Medanta.
Dr. Akram
Sure.
belongs to National Institute of Chest Disease Hospital. I belong to National Institute of the Cardiovascular Diseases.
Oh, I see.
So far.
Is yours not the same center? Is yours a different center?
My one is the
Cardiovascular
national,
is not on the same site?
Yeah, we have centers, but Foyz is not joining there. We have very weak cardiac facilities there.
You have cardiac as well. Okay.
Yeah.
All right. Okay. So
Okay.
we are a full house. We have got 100 participants on, and the time is 5 o'clock. So let us start today's talk. Now I want everybody first to switch off your microphones, please. Everybody just switch off your microphones. Just remember to do that. Where is it? Mute all. So everybody is switched off, and now I will start my talk.
Prof, don't please, sorry to disturb, please don't forget to record that.
Yeah, absolutely. Thanks for reminding me. That's very, very important. So here we are. That's going live now. Okay, and then we need to start recording, right? Okay, record on this computer. Okay, so good evening to everybody. Welcome to this, I don't know which session this is. I seem to be going on and on for the last so many weeks. So anyway, welcome to this session. This is part of the basic session. As I told you, I will be covering two sides of things. One side is going to be basic anatomy, physiology, and stuff like that. And then on the other side, I'll cover all the high-end complex surgeries. So yesterday or day before, when I did endobronchial surgery, which was, I think, quite a revelation to a lot of people who had never seen that sort of high-level interventions. So today, I've decided to go back to the basics. Please make sure, everybody, that you have a 200-page notebook in front of you, a pen and paper in your hand, because we are going to try and identify structures, okay? The whole idea of this topic is to understand normal anatomy, okay? So everything that I teach is going to be normal anatomy. And then if we are doing okay and we've still got time, then I've got at least 100, 200 slides on abnormal anatomy. But the main purpose of this talk is that you understand normal anatomy. That's the most important thing. The moment you know normal anatomy, then you can easily correlate into abnormal anatomy. Vivek, please switch off your phone. Switch off your microphone. Okay, thank you. So the bottom principle of radiology is, as I said, it is absolutely vital to know the normal anatomy. And the most important thing that you've got to remember and you've got to train your mind is that this is a 2D image of a 3D structure. So whenever you look at any investigations, whether it is chest x-ray, CT scan, PET scan, the image may be 2D, but in your brain, the vision should be 3D. And that only comes with practice. You really have to practice a lot. And more importantly, you've got to know the normal anatomy quite clearly. It's only when you know the normal anatomy is when you know what is the abnormal anatomy. And so it is very, very, very important to think like that, okay? So all my focus today is going to be on normal anatomy. I really want you to get it across to you. Now, the most important thing that you must remember is that the eyes cannot see what the mind does not know. This is a standard philosophy in life where everybody tells you that if you don't know what you're looking at, your eyes will not pick up those subtleties. But in radiology, it is even more important. It is not, the first sentence that I told you is actually not correct. In radiology, the reality of life is the eyes will see what the mind has already decided. So if you have clinically seen a patient and you've already decided that this guy has got pneumonia, then rest assured everything that you see on the chest x-ray will look like pneumonia to you. And what is even worse is if you have already read the CT scan or the x-ray report, then that is the worst thing you can do for the patient. I promise you. So the first principle of understanding radiology is to never ever read a report. All reports should be read after you have finished seeing the radiology, made up your own mind, made up your own diagnosis, so that you can confirm your diagnosis on the radiology report. Many times in my clinical practice, I have actually gone down to the radiologist after I read his report and I told him, this is wrong, this is wrong, this is wrong. And that comes from experience, because I see the radiology first. Only then will I read a report. Because remember, it could be just a junior registrar reporting who has no clinical information. He's sitting in an air-conditioned office. He probably may be in a diagnostic center where they do wholesale reporting of chest x-rays and wholesale reporting of CT scans, and he does not know two hoots about the patient. Also important is that when you send in a request, I see a lot of people just write chest x-ray. They do not write clinical information for the patient. So rubbish in is equal to rubbish out. The quality of the report is only as good as what you have asked the radiologist. If you haven't asked the right question, rest assured, he is not going to give you a correct information on the report. So very important that when you are reading radiology films, when you're reading radiology x-rays, please do not read the report first. Absolutely vital. Okay, the last thing you want is to misinterpret or misunderstand a clinical situation. That is why when you finish examining a patient and you've listened to his chest and done everything, please reach a differential diagnosis. Do not reach a diagnosis, because if you reach a diagnosis, then everything else gets shut off. And then when you look at the chest x-ray or CT scan, you cannot see anything else beyond that diagnosis. So remember, the eyes will see what the mind has already decided. So better when you're reading a radiology film or a radiology image, please keep your minds wide open. Okay, absolutely wide open. You are the guy who knows the patient. You are the guy who's seen the patient. You are the guy who has examined the patient. So your interpretation of the CT scan is going to be 10 times better than the radiologist who has not seen the patient. So please, this is the most important slide of this presentation. Never, ever read a report. Make up your own mind after seeing the images. You can refer to the report afterwards. A lot of people do online consult with me and they send me written reports. I will never accept it. I do not accept an international consult until and unless the images are sent to me, because my interpretation of the image will be 10 times better than any radiologist, because I have got years of experience in dealing with the clinical side of things rather than sitting in an AC office looking at the screen. Okay, so the first question that everybody gets asked in the exam is risk of radiation exposure. So let's get that out of the way. The first risk is the chest X-ray, which is not 0.1 MSV. That is the unit of measurement. So 0.1 is a chest X-ray. As you go up, you will find that CT scan is somewhere in this range, which is 10 MSV. Okay, and then everything else tells you what are the radiations. Okay, so look at that recommended radiation. Chernobyl accident was 350, so almost 35 CTs exposure was received by the Chernobyl. Even worse was the Fukushima. The Fukushima on March 14 per hour was exposing to 400 MSV. So you can imagine what is the level of radiation that these people got with the nuclear disaster. But chest X-rays lie right at the bottom, 0.1 MSV. Most of us are exposed to natural radiation, which is 2 MSV per year, okay? So really a chest X-ray is quite safe. A CT scan is also quite safe because you're very much in the orange zone, very much in the yellow zone. not in the orange or the red zone. So doing a CT scan really is not that much of a problem. If you look here again, you will see that this is equivalent to the time period that you would get from natural background radiation, how much exposure you get. So if you do a chest X-ray, it's equal to 2.4 days of radiation over a year, okay? And if you look at a CT scan, CT abdomen and chest, it's about 400. Barium enema is also around 400, which is 2.7 years of exposure, of natural exposure. So it has got exposure, but it is not so dangerous. That's the point I'm trying to make, okay? Of course, in a pregnant lady, you don't want to expose people to CT scans, but because the fetus doesn't like radiation exposure, and you can get fetal changes because of CT radiation. And in that scenario, MRI might be an answer when you're trying to when you're trying to analyze pathology in the patient, because MRI does not have radiation. It is magnetic field. It's a different technology, a different terminology, and I'll talk about it when I finish this talk. Okay, so what happens in a chest X-ray? In a normal chest X-ray, you've got a cathode ray tube. The beam comes in, it excites the negative electrons. The negative electrons go and hit the anode mirror, which is the focus of the rays. So the rays hit the surface, they get focused, and then they come across onto the organ that you're going to shoot, and then you've got your plate at the end. So you get a positive negative image on the other side. So in the chest X-ray world, we do three basic types of chest X-ray. First is a posterior anterior view. The second one is an anterior posterior view, which could be erect or which could be supine. Okay. Most X-ray chests done in a radiology room are PA. Everything that's done in the ICU is AP. So what do you mean by PA? In the PA, the beam is coming from the back, P to A, posterior to anterior, and the plate lies on the chest of the patient, okay? The distance between the beam and the plate is 1.8 meters. This is a standard protocol for doing a chest X-ray PA, mostly done in radiology room and mostly done on deep inspiration. Because when you take in a deep inspiration, the diaphragm goes down and you see all the crevices and the recesses of the lung, particularly into the costophrenic and the cardiophrenic angles. So always the best film is on deep inspiration, okay? So this is how it happens. Here is your, this thing, the patient is standing here, the plate is here. The structure is closest to the plate will give you the best image, okay? That is the philosophy behind this. So the structure closest to the plate gives you the best image. Hence, you get a very good image of the heart here. Can you see that? Very beautiful, very crisp. The sharpness is very good of a heart when you're doing a chest X-ray PA. As opposed to that, an AP view of a chest X-ray is the beam lies anterior, which is in front of the patient. It goes from anterior through the chest to posterior, and the plate lies behind the chest, behind the back of the patient. What you do in a ICU setting, that is a AP film. Now the distance between the beam and the plate in an AP film is shorter. It's 1 meter, okay? And this one is mostly done in the ICU, and the supine one, which I mentioned, is done in an unstable or an unwell patient who cannot sit up for whatever reason. But the best image of all three is the chest X-ray PA. In your clinic, if you ever have to ask for a chest X-ray, you must ask for a PA view. In the AP view, what is happening is the heart is lying further away from the plate. Can you see that? The heart is further away from the plate. The spine is closer to the plate, and the rays are diverging, and there is a concept of magnification. Hence, when you see a PA film, the heart appears to be smaller when you see an AP film, the heart appears to be larger, but the crispness of the image, the sharpness of the image of the heart in a PA film is much higher than an AP film. So you see that it magnifies the anterior structures. The heart hilum are magnified, hence they are less sharp. The scapula is present in an AP film, which obscures the pathology in an upper lobe because you are standing with the plate. The plate is behind the chest. The scapula is closest to the plate. So it always forms a shadow. And very often, because the scapula is superimposing a 3D image onto a 2D image, many times you might actually miss pathologies in the upper lobe when you are looking at AP images, okay? And also it's a low energy image because you're closer to the chest. You cannot go that far away with an AP. So the penetration of the rays is less. Hence the definition of that image is less. So it's very important to understand that AP is not the ideal chest X-ray. But of course you got to do AP when the patient is in the ICU. You cannot do it PA because the patient is on a bed. So AP is a compromised view. It's okay to get a feel of what's happening around the chest, but not good to pick up subtle pathologies or smaller changes. It's very good for looking at gross changes like pleural effusion and things like that, okay? So this is the view. This is PA, this is AP, okay? So in a PA, all the borders are very sharply defined, very, very crisp. The heart looks smaller, but it is more, more crisp. It's like the picture that when I spoke about video editing, I told you about optical zoom and digital zoom. This is digital zoom. And so because this is digital zoom, this image is more blurred. The heart looks bigger. You really cannot comment whether this guy's got cardiomegaly or is there any subtle changes. And more importantly, look at the borders. The borders are not very sharp as compared to a PA view. And particularly look at these recesses. These recesses are very, very well defined on a PA view. They are not well defined on an AP view. Look at this recess. You really cannot say. As compared to that, you can very clearly look at this recess, the cardiophrenic recess. You can also see the lung overshadowing on the top of the heart. So, you know, this is a 3D image on 2D. So you can actually see all the way down to the bottom of the lung. Whereas on the left side, you cannot really comment on what is happening in the lower lobe and in the lingula of the heart. You cannot comment here on the left side. Whereas here, you can clearly see that lung coming anterior. You can see the superimposition of the image. You can see the diaphragm very sharply. Can you appreciate the diaphragm can be seen? The left diaphragm can be seen all the way up to the midline. On this side, you cannot see the left diaphragm clearly because it forms a very, very dull image. And hence, the best image to take is a PA view. Okay. All right. Is this clear to everybody?
Yes.
Yes, sir.
Yes.
Very basic stuff, but I'm going to start with basics and then go to advanced. You'll be surprised the number of times I have caught out students in the exam with simple PA and AP, and I've asked them to explain how do you take an AP or how do you take a PA, and they cannot explain how to take an AP or a PA. And I'm not talking about undergraduates, I'm talking about postgraduates. So please make sure that you understand the philosophy and how is the technology used for taking the X-ray. So here is the picture of black to white, okay? Black to white. And chest X-ray lies in this domain. Okay, all structures within the body are actually represented from black to white. The important thing to remember is that air lies on the right-hand side of this scale, which means air is black. That is very, very, very important to understand, that air is black. Particularly when you're reading films, it really matters when you see black tissue in the black air in the subcutaneous tissue. It clearly tells you that something is wrong here. That's how you pick up the pathology. So this is a chest X-ray, and we're going to go through each one of this, and I want you to try and possibly draw diagrams if you can. If not, you can go back and revise on my on the recorded video. So let's look at this chest X-ray. Let's look at highlights of some bony shadows. Okay, so it's very easy, it's not difficult. We can see the clavicle, we can see the ribs. This is a PA film. I know that it's a PA film because I can see the size of the heart beautifully, the margins are beautifully done. I can count all the way on the ribs. Can you see? I can count all the way up to 7 ribs. If you can see 7 ribs on an inspiratory film, that is a PA film, okay? So you have to count the ribs to understand the pathology that is happening. So is it making sense? This is what is dorsal and what is ventral is also important to understand. Dorsal means posterior and ventral means anterior. So the ribs are starting from this junction and coming all the way across. And whenever you review X-rays, the same thing, look on the left side, follow the right to the left. So the way to count the ribs is to count the first rib and then follow it down, second, third, fourth, fifth, sixth, seventh, okay? So you've got to follow each rib, and that is how you will be able to tell where is the pathology in relation to the rib or in relation to the zone of the lung, okay? Now, again, this is the next film. We are now going to look at the markings of the pleura. So look at the film again, okay? I will slow down in this phase. I'll slightly slow down because I want each one of you to look at a film. And the question is, where are the markings of the pleura? Can you, in your mind, make up where are the markings of the pleura? So I'm going to flash it in a minute, and I'm going to go back. Can you see that? The important thing to remember is it's all the way down here. And this will only come in a PA film. So this is the marking of the pleura. And these are the 2 angles, the costophrenic angle and the cardiophrenic angle. The cardiophrenic angle and the costophrenic angle. And when you are analyzing a chest X-ray, you must look at all these things that I'm going to tell you over the next 40 minutes or so. So this is a pleura. Let's look at the next chest X-ray, okay? Now we're going to look at the heart margins. So concentrate on that. Get a 3-dimensional view into your brain when you're looking at a 2-dimensional picture. So concentrate on it. Try to understand where is the right atrium, where is the right ventricle, where is the left atrium, where is the left ventricle, and more importantly, where is the aorta and the pulmonary artery. 6 structures that you need to know in this picture. So this is the orientation. Can you see that? So most of the right border of the heart is formed by the right atrium. Does it make sense? Most of the left border of the heart is formed by the left ventricle. The basal border is formed by the right ventricle. And then you have this little thing poking out, which is actually the left atrial appendage. And then you've got the notch of the heart. And more importantly, you've got the superior vena cava on the top. Okay, have a look again. Try to identify these structures as I'm going through it. So right atrium, left ventricle, right ventricle, aortopulmonary notch, where lies the left atrium, aorta, and SVC. Okay, is this clear? Okay, let's move on from here. Let's look at another chest X-ray. So let me first try to explain to you how the shadows come. So here is the left atrium, which lies most posteriorly, and the left atrial appendage is peeping out to the left. The right atrium is superimposed on the left atrium. The left ventricle is superimposed on both of these, and the right ventricle is superimposed on the left ventricle. Okay, left atrium, left atrial appendage, right atrium, left ventricle, right ventricle. So now if you look at this picture, you actually find the 4 borders of the heart as I defined it. Can you see that? Right atrium on the right side, left ventricle on the left side, right ventricle on the base, which is the pleural diaphragmatic surface, and the aorta on the top, and the SVC to the right side. Okay, so that is the first understanding of cardiac pathology. Okay, now let's see what else can we see on this chest X-ray. Is it clear to everybody? I want a feedback because this is very
Yes, sir.
Yes, sir.
Yes, sir.
Very clear.
Yes, sir.
Have you drawn the diagram? Please draw the diagram,
Yeah,
because
yes.
that will help you. Okay, if you want, I can repeat it. If at any point you want me to repeat something, I'm very happy to repeat it, because this is once in a lifetime lecture, and you must understand it now for the rest of your life. Okay, all right, let's look at the chest X-ray again and see whether we can understand any other things in the mediastinum. So look at it carefully and try to identify this structure. Okay, go back. Try to identify the trachea, the carina, the right pulmonary artery, and the left pulmonary artery. Is it clear? Trachea, carina, right main bronchus, left main bronchus, right pulmonary artery, and left pulmonary artery. Okay? All right. Now, one point which I want to make very clearly at this stage is that the left pulmonary artery loops over the left main bronchus. Hence, the left pulmonary artery is always at a higher level than the right pulmonary artery. If any reason you find that the left pulmonary artery on a chest X-ray has gone down or is at the same level as the right pulmonary artery, that means there is a pathology there which is pushing the left PA down. Did you understand this philosophy? The left pulmonary artery arches over the left main bronchus, which runs horizontally across. Hence, the left pulmonary artery is always at a higher level than the right pulmonary artery. Okay? The right pulmonary artery lies next to the right main bronchus. It doesn't arch over it. Hence, it is at a lower level than the left pulmonary artery. Everybody happy with this?
Yes, sir.
Yes, sir.
It looks at the same level though, sir.
No, it is at a lower level. I promise you this. Okay.
Okay.
All right. Chest X-ray. Look at mediastinal lines. There are some lines which you have to remember, which will help you to identify various pathologies. Okay. So this is the paratracheal line. Look, stand back and look. Don't stare into the computer close off. Stand back and look. This is the left paratracheal line next to the trachea. If you look carefully in a well-exposed film, you will see a paraspinal line very clearly seen at the back behind the heart. Again, if you look carefully, you will see an azygoesophageal line or recess. Can you see this? It's very, very clear, no doubt about it. Look to the left side, there is a para-aortic line, and here lies the aortopulmonic window, aortopulmonary window. So whenever you look at a chest X-ray, look at these areas, because this is where you will miss pathology, particularly in this area. So if you don't see this line being highlighted, something is wrong, okay? So if this line is not clear on the back of the heart, then it means that there could be a hernia coming at the back, pushing its way and disrupting that line. And that hernia is called as a Bochdalek's hernia, which is at the back of the chest, okay? Paraspinal line is very important to understand because neurofibromas and spinal tumors lie in this area, and they will disrupt this line because of the presence of the tumor. Paratracheal line is important to understand because lymph nodes lie in this area, and lymph nodes will disrupt this line. Aortopulmonary window is very important to understand because lymph nodes, particularly in lung cancer, lie in this area. And more importantly, the left recurrent laryngeal nerve lies in this area. So if a patient presents with cough, hoarseness of voice, and a fullness in the aortopulmonary window, be very worried that you might be dealing with a malignancy. And a para-aortic line is very important on the left side, A, to look for any aortic pathologies, or to look for left-sided paravertebral tumors or spinal tumors at the back of the heart, at the back of the mediastinum. So important to know each of these lines. They are the basis of understanding a chest X-ray, okay? Let's go to this one now. I gave this to everybody. I want you to actually look through this and tell me how many of you got this right. Don't tell me, but for your own self, go through it. So we said that this is the SVC. This is the azygoesophageal recess, that long vertical line. This is the right pulmonary artery I showed you earlier. This is the right descending pulmonary artery. So it's just a continuation of the pulmonary artery. This is the right atrium, the cardiophrenic angle, the liver, the breast shadow, the costophrenic angle, because it's a female, you can't see it that well. The knuckle of the aorta or the aortic arch, the aortopulmonary window, the descending pulmonary artery on the left side, the left atrium peeping out here, with the left ventricle forming the left border of the heart, and then the gastric bubble and the splenic flexure of the colon and descending aorta. So this is how you must actually analyze the whole chest X-ray. The moment a chest X-ray comes to you, all these structures must immediately come into your mind. You must think of all these structures, and you will then get very good at picking up pathologies. Of course, nowadays we are all used to CT scans, but really the chest X-ray is a very good tool for giving you a lot of information, particularly an old chest X-ray. So whenever you have a patient who comes in with a pathology and you've got a CT scan showing some changes, you ask for the old radiology. And very often the patient may not have had a CT scan. He would have had only a chest X-ray. If you don't know how to read a chest X-ray, you will miss the fact that this patient had a same size tumor 3 years ago. And on the current CT scan, it is still the same size tumor. You're not so worried. It might be anything. So very, very, very important to understand chest X-rays, okay? Now, lateral views. Let's look at what forms the lateral views of a chest X-ray. I think a lot of people don't understand what is a left lateral view and what is a right lateral view. So the left lateral view means the hemithorax, which is closest to the film. So in a left lateral view, the X-ray is coming from the right side of the chest across the mediastinum into the left side and then hitting the film. That is a left lateral view. A right lateral view is when the X-ray is coming from the left side, going across the mediastinum, hitting the right side, and then hitting the film. So the side closest to the film is the left or the right lateral. And it is important to understand that the side of the pathology should be kept closest to the film. So if you're looking for a tumor in the right middle lobe, then do a right lateral film. A left lateral film is no good. If the pathology is close to the right side, it will give you a better image, a sharper image on a lateral film. Hence, it is very important to keep the side with the pathology close to the film. Did you understand that concept? So this is, what side is this? What view is this? Can somebody just quickly say?
Left lateral.
Thank you. So this is a left lateral view, and we are looking for pathology in the left lung, left posterior mediastinum, or the heart. You understand that? So this is the philosophy behind it. Now let's look at these views and try to understand what a lateral film looks like. A lot of people do not understand lateral films. I promise you. A lot of people do not understand lateral films. So let's look at it, okay? Can you see these structures? The right pulmonary artery, the left pulmonary artery, the trachea, and the scapula, sorry. Look at it again. Look for the trachea. Identify where the trachea is. Look for where is the right pulmonary artery and the left pulmonary artery. And identify what is the border of the heart, just grossly. I don't want you to go into detail, just grossly. And another important structure that you can see very clearly if you stand back is the esophagus. So this is esophagus, that's trachea in the front, that is your right pulmonary artery, that's your left pulmonary artery, and that is the heart, okay? Very, very basic understanding. The spine is at the back, you can see it pretty clearly, the spine. And now let's look at what is the orientation of the heart in a lateral film. So in a lateral film, now imagine the 3D version of this, okay? I've put this on the side to give you an idea of what is the 3D version. So the right ventricle is away from you, okay? So this is the right ventricle, this is the left ventricle, and this is the left atrium. So what you really see on a left lateral film is left atrium, left ventricle, right ventricle, and right atrium. Is this clear? Is this picture clear? Yes or no? Hello?
Yes, sir.
Sir. Yes, sir. Yes,
Is
sir.
it making sense or no?
Yes,
Yeah,
sir.
definitely.
Thank you. Okay, so understand the areas of the heart is quite important. So the upper shadow is left, the RV is retrosternal, which means behind the sternum. The lower border is the left ventricle, okay, the posterior border. Okay, let's continue with some more views, okay, just to understand normal x-rays. In this view, in a lateral view, it's quite good to see the contours of the diaphragm. And it's a very good way to identify which diaphragm is elevated and which is not elevated. It's a very, very nice way because you will see the pathology quite clearly and you will see the diaphragm quite clearly. The important thing to understand is that the right diaphragm is always seen all the way to the front and the left diaphragm to the heart border. So you cannot see the left diaphragm coming to the front because the heart and the right diaphragm comes in the way. So this is your right diaphragm in a lateral view. The one that you're seeing going all the way to the front is always the right diaphragm. And then the one that you're seeing here is the left diaphragm. It stops at the heart. You cannot see it very clearly. Again, the mediastinum on a lateral X-ray is divided into anterior, middle, and posterior. It's a different view. You just get used to it. This is the view that we operate on in the patient. So this gives you a better understanding of thoracotomy and things like that. The same point which I made earlier, very important to understand that the left pulmonary artery passes over the left main bronchus. Hence, the left pulmonary artery is always higher than the right pulmonary artery. Just stay with this information, okay? Whenever you look at more films, you will understand what is the point I'm trying to make, okay? So always remember the left main PA is always higher than the right main PA. This is an MCQ, by the way, okay? So remember this in the exams. So let's look at some more things. What else can you see on a lateral view? Hilar enlargements, they come out beautifully. Can you see the hilum? On this, you cannot see the hilum as well because it's all being superimposed. Whereas this is really highlighting the hilum. You can see that there is a pathology in the hilum. And usually rounded structures at the hilum represent lymph nodes. That's the standard thing that we see. And you got to look at the paratracheal line or the strip. This is the paratracheal line, and that's getting disrupted here. So you know that there is something not right in this area. Okay. The lateral view is very, very good in pediatrics because very often, not just in pediatrics, even in adults, because the foreign body, when it is swallowed on a PA view, you cannot really tell where is the foreign body. Is it in trachea or is it in the esophagus? And in a child, usually difficult to get a PA view. You end up with an AP view. But this is, of course, a PA view. But look here. Here you can very clearly see the highlight of the trachea. Can you see that? So the trachea is in front, hence this foreign body is behind the trachea, hence it is in the esophagus. Yeah? Okay. Let's look at this one. Here, the foreign body is lying, actually the direction and the angulation is already giving you a clue as to where this is. This is less likely to be in the esophagus, more likely to be in the bronchus, but if you look here, it is confirmed. Here is the trachea, here is the bronchus, behind, if you look carefully, is the esophagus. So you can very nicely say that this is actually in the bronchus rather than in the esophagus. Okay, so a lateral view works very, very well for foreign bodies. So how do you analyze a chest X-ray? The chest X-ray should have a systematic approach. Okay, you got to look at the heart. You start from the center and go to the periphery. I don't mind some people do periphery to center, but my advice is most of the pathology is all in the middle. So start from the heart, look at the mediastinum, look at the hilum, move laterally, look at the lungs, look at the thoracic wall, and most important is don't forget to look at the abdomen. I mean, the number of times where I have seen in the exam actually somebody missing gas under the diaphragm because they are so focused on that little spot that they see on the lung that they forget to realize that there is actually gas under the diaphragm. So don't forget to look at the abdomen. It's important when you look at a chest X-ray because most of the times they will take a chest X-ray which does give you the upper abdomen quite clearly. Look for normal first. Once you've seen the normal, then look for abnormal. This is another mistake which a lot of people make. The moment you put up the X-ray, they get so focused on that one little shadow that you're seeing that they forget to see the opposite side. They forget to see the normal structures in the anatomy. So whenever you're interpreting a chest X-ray, whether it's a CT scan or a chest X-ray or any radiology, always, always, always start with the normal first. Look at the normal, make sure that you understand what is normal, and then look for the abnormal. Don't get hooked onto the abnormal. So look for the abnormality, look for the pattern, the size, the shape, the distribution, the position where it lies. And most important, whether you're doing CT scans or whether you're doing chest X-ray, please, please, please reach a differential diagnosis. In the exam, don't just jump to it. Of course, many a times it's very obvious what the answer is. But if I ask you what is a different diagnosis, you shouldn't get stuck on it. You must at least have one or two differential diagnoses ready because chest is really complicated and sometimes many pathologies look the same. And you might think only of one and completely miss that the possibility of this being something else. So always try to reach a differential diagnosis, not a diagnosis. Always say that this is my first choice answer, but I would like to rule out A, B, and C. Always, always. Whether you're doing chest X-ray or CT scans, I really want you to do that. Particularly in a chest X-ray, you must try to understand what is a differential diagnosis. As I told you before, old films are mandatory. There is no, if somebody asks you, they give you an imaging and they say, what is the next step? Or if I give you only one choice, what do you want to do next? You must say, please show me the old films. This is a classic exam trap. It's a classic exam trap. And the moment you say, show me old films, everybody's happy and we all get along with it. And the most important thing, of course, you're looking for is any change in size, any change in the shape, any change in the location. But do not see CT scans without seeing chest X-ray. Another golden rule of radiology is please don't just jump to the scan and keep looking it up and down and scrolling up and down all the time. If I was you, I would say, can I see the chest X-ray first, please? And that the examiner will tell you, no, go ahead with CT. That's fine. But most of the examiners will appreciate if you ask for a chest X-ray, because most of us actually grew up in an era of chest X-rays. I grew up in an era where we used to go down to the radiology and we had these 4 or 5 huge pots with all sorts of chemicals, and we used to shoot the film, take the film, dip into one, then dry, dip into the next, and things like that. So we are masters at chest X-ray. CT scan has come later on. So most of your examiners would actually be from an era where they love chest X-rays. So please do not see a CT scan and just say, this is it, this is it, this is it. Always say, I'd like to see the chest X-ray first. And then if he says, no, carry on with the CT, that's fine. That's not a problem. Okay? All right. Whenever you're looking at a chest X-ray, please, for God's sake, make sure it's the correct patient. It is the most important. The identifier is very, very, very important. Okay? And the identifier usually is either the name of the patient, the hospital number, the age of the patient. Very important. These are the 3 identifiers which are supposed to be mandatory on any film, whether it's CT or chest X-ray. Do not start interpreting any radiology without identifying that it belongs to this patient. Make sure you see the side annotation. It's very helpful. It tells you which is the right side, which is the left side, particularly if you're dealing with dextrocardia and you got L on the other side, heart on the right side. The L will guide you to the fact that this is dextrocardia. So don't forget annotation. Make sure that it covers the whole area, including the chest and the upper abdomen. Very often you see a shabby chest X-ray with half the chest. Do not try to comment on that, okay? Look at the depth of inspiration. An ideal chest X-ray should be all the way down, 7 ribs visible on the right side. 7 ribs. It's very important, okay? And that is, and of course, whether the film is rotated or non-rotated. The costoclavicular junction and the trachea will give you an indication whether this film is rotated or non-rotated. So these are standard things on a chest X-ray, nothing different. Look for depth of penetration. See whether you can see the heart, you can see the vertebral spine or not, and things like that. And that will give you an idea onto what is happening. Absence of artifact is important. Make sure there are no, the shirt has been off. There are no pens in the pocket or hook blouses or bra hooks. Those are not good. The hooks will cause artifacts and they are not good. And look for the projection. Make sure that it is a PA film and not an AP film. And if it is an AP film, interpret it with caution, because an AP film is done at 1 meter and heart appears bigger, mediastinum appears bigger than the AP film. Okay. When you're looking at structures, follow A, B, C, D, E. Okay, this is the easiest way. You will never miss anything if you follow A, B, C, D, E. Airway, breathing, which is lung, circulation, which is the heart, diaphragm, and external structures. Very easy. Even when you're doing CT scans, follow A, B, C, D, E. Airway, breathing, lungs, circulation, which is the heart and the mediastinum, diaphragm, and external structures. Okay? And now we'll go through each one of them. This is easy. Airway, we know what it is. Trachea, carina, main bronchus, not a problem. Breathing is lung fields. Don't forget to look at the lung fields. Look at the lobes of the lung. So let's try to identify what are the lobes of the lung. Quickly, we'll go through it. So look on the left side here. Try to see which is upper lobe and which is lower lobe on the left side on this chest X-ray, okay? And I will point it out to you. The important thing that you got to remember in terms of the lobes is that it will be projected anteriorly, okay? And it is projected quite superiorly. So this looks like the upper lobe, but a lot of the left lower lobe comes superimposed on the upper lobe. So very often a pathology in this area may be very difficult to understand. It's not always very clear to see the fissures, the minor and the major fissures. It's not always very clear. So just the zones is what you have to work with rather than lobes. If I've asked to speak in an exam, I would say the there is a mass in the left upper zone, or the left middle zone, or the left lower zone. The middle zone corresponds with the hilum, and everything above is upper, everything below is lower. So try to talk of zones rather than talking of lobes. On a CT, you can more accurately talk about the lobes. Again, see in a lateral film, you can see that the left and the right lower lobe superimposed on each other. Let's look for the left upper lobe. So there is a large area of superimposition between the lower lobe and the upper lobe. Can you appreciate that? And that is what you have to understand, that something which is present here does not necessarily belong to the lower lobe. It might be upper lobe because it's a 3D reconstruction. And that is why a lateral film will give you a very good idea whether it's in the upper or the lower lobe. That is the reason why you do lateral films. Okay? All right, let's look on the right side now. Everybody concentrate on the right side of the chest. That's the right upper lobe. Look at the lateral film, how well you can say it. That's the right middle lobe. And that's the right lower lobe. So an AP does not give you, a PA does not give you exact correlation of where is the upper lobe. A huge area of the upper lobe overlaps with the middle lobe, overlaps with the lower lobe. Okay? And that is why a lateral film will give you a good view of where is the upper lobe, where is the middle lobe, and where is the lower lobe. Okay? All right. So far, so good?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Is it making sense or is it too basic for you guys? Are you very advanced?
No, no, we're not advanced.
I'm happy.
Is the very essential.
Okay, good.
Basic
good.
is important.
Yeah, okay, so let's look at the circulation. All right, let's do this. So look for right-sided vascular structures, which are the azygous vein. Look on the left side for left atrial appendage. Look for the aorta pulmonary window. Identify the main pulmonary artery. Look at the hilum and look at the right paratracheal stripe. Okay, this is what I showed you in the first film when I started off with the various lines and the stripes. Very important. Okay. In terms to diaphragm, remember right side is usually higher than the left side because of the presence of liver. Don't forget gas under the diaphragm. Usually if a diaphragm is flattened, then it means there is hyperinflation. Okay, the dome of the diaphragm, the curve of the dome of the diaphragm is quite important. Otherwise, it will you straight away looking at the flattening of the diaphragm can tell you that you're dealing with emphysema. It's such an easy diagnosis once you understand how it looks like. Don't forget elevated domes of diaphragms could be because of paralysis, could be because of eventration. Okay, so keep that in mind when you're dealing with these things. Hernias, always in a diaphragm, real key is hernias. That is why a lateral view might help you pick up some of the hernias. Okay, and we'll talk about it in more detail later. What about the external structures? So we spoke about A, B, C, D. What about the external structures? What do we look for in a chest X-ray? Always look for the ribs, 10 posterior, 6 anterior on deep inspiration. Okay, so you should be able to see these. Look for clavicles, whether they're coming and joining in the center. Gives you a good idea of a rotated film or a straight film. Vertebrae, you will be able to see up to T5 quite well on a chest X-ray, well-exposed chest X-ray. Look for the sternum, seen better on a lateral film rather than an AP film. And look for normal variants like subcostal lines, costal calcifications, and pectus. And I'll talk about these later on. Now, the most important thing, this is the key to a chest X-ray, okay? Because if you don't even pick up a pathology, you will not ask for a CT scan. That's the problem. So look for hidden areas. It's very, very, very important in a chest X-ray. A 3D film represented as a 2D film, so there will always be superimpositions. And there are certain areas which are classical where pathology is missed. These are called as hidden areas of the chest. The apices of the chest, very important, because the clavicle comes in, the first rib comes in, and if it's a PA film, the scapula comes in. So the lung, a small lesion or a solitary pulmonary nodule on a lung apex is frequently missed by young students. Not just young, but even senior people, I've seen them miss a tumor in the lung apex. More importantly, calcification of the first rib or calcification of the medial border of the scapula, of the clavicle, may give you a false impression of a presence of a tumor. So don't forget that everything that you see may not be cancer. Sometimes simple calcification of the left upper rib, of the first rib coming anteriorly, head on towards you, may actually feel as if there is a cancer there. So it's important to take a lateral film, and that will do away with that complex. The hilum is a very complex area. It's very difficult to diagnose things until and unless you're used to seeing the hilum hundreds of times. So whenever you see the chest X-ray next time, please follow this pathway which I told you and look at each one of these structures, and you'll be surprised how much you will find within a chest X-ray. Don't forget the area behind the heart. Very important. On a PA view, you will miss things behind the heart. Don't forget the costophrenic angles. It's deep inside down there, and sometimes a small lesion may lie in that angle and you might miss it. And don't forget to look below the diaphragm, okay? Very often people miss things below the diaphragm. So these are the hidden areas of the chest X-ray. Lung apex, the hilum, behind the heart, and below the diaphragm. So next time you see a chest X-ray, think of me, think of this hidden area and look for it specifically. Try to identify each one of this area and see if there is a pathology behind there. So what about a silhouette sign? Everybody talks about a silhouette sign. Well, it's the loss of normal pathology. And the one area where you see silhouette sign is either in the lingula on the left side or left lower lobe pathology. Okay? Because the heart is lying in the front. This thing is going behind the heart, and it casts a faint shadow, a silhouette. And that may actually, if you're not looking for it, you will not pick it up. So a silhouette sign is a very good idea. So this is your lung, this is your heart, and anything in this area will be missed. And this is lingula of the upper lobe, and this is left lower lobe. Okay? The blue is lingula and the left is left and lower lobe. So look at this carefully now. Everybody see this X-ray. Okay, see this X-ray. How many of you can put hand on your heart and say, I pick up the pathology? Look at it. Did you see it? That is the importance of a silhouette sign, okay? You must look carefully in the shadows behind the heart. So to be absolutely certain as to what you're seeing, all you have to do is ask the patient to take a lateral film. See this huge patch of atelectasis, early pneumonia, has been missed on this chest X-ray. Very clearly you can see it if you know what you're looking for. I promise you 95% of you would have not seen it, but it comes with experience. It's only when you're looking for it. Look at the left diaphragm is elevated. That's the other point. It gives you a hint. Nobody picked this up, I'm sure, that the left diaphragm looks as if it's elevated. And there is something happening in the back of the heart, and that is a silhouette sign. So next time you see a chest X-ray, don't just have a look and jump to the CT scans. Particularly exam-going people, please look at every chest X-ray and try to identify all these structures which I asked you to identify. And slowly you will become so good at it that the CT will be a piece of cake for you. The moment you've seen something on a chest X-ray and you correlate it with the CT, you're on a winner, okay? Now there's something called as Curly's lines. People talk about it. These are signs of fibrosis. And this is what is a Curly's line. Look carefully on this chest X-ray. And if you look laterally, there are some lines coming into the chest, okay? These are the Curly lines. Look carefully again. I don't mind waiting a couple of seconds. See these lines coming in? These are called as Curly lines, usually signs of interstitial fibrosis, because there is fibrosis developing in between the septae of the bronchi. And that's called as Curly's lines, okay? Meniscus sign, easy one, everybody knows it, but sometimes you might miss it because it's a very subtle thing. So look on the left costophrenic angle, and there you are, a meniscus sign. So there is definitely some fluid collecting in the left costophrenic angle. Can you see that? Okay. let's look at this X-ray. How many can point out as to I've given the diagnosis on the top? I'm sorry about that. But how many pathologies can you pick up on this chest X-ray? Just examine yourself. How many pathologies can you pick up? I'm going to wait for 2 seconds or 5 seconds. Okay. How many of you got all of these? Okay, it's very important. I'm going to go back and now start looking again. Look carefully into the chest X-ray. See that the diaphragm is flattened. There is hyperinflation of the lung. The chest is widened. It's a barrow shape. Look at the shape of the trachea. You can very clearly see that this is a saber sheath trachea, typically seen in an emphysema. Look at the apex and look for the markings, the bronchovascular markings. There is decreased marking in the apex, suggesting that this patient has got some emphysematous change. And look for reticular findings with the evidence of fibrosis within the parenchyma of the lung. Does this make sense? Hello?
Yes, Prof.
Yes, sir.
Yes, sir.
Yes, sir.
Now, again, I am going to
Yes, sir.
turn this to lateral, and I want you to look at that. And this is the same patient now. You already know what are the findings on this chest X-ray. I want you to try and correlate those findings on the chest X-ray. I'm going to leave it for a few seconds. Can you see that? Did you appreciate the flattened dome of diaphragm? Did you appreciate the barrel-shaped chest?
Yes,
Did you
sir.
appreciate the retrosternal area has gone, there's increased because the lung has come in front of the heart. And more importantly, did you look at the trachea and appreciate that the trachea looks different? So this is called as a saber sheath trachea. It is the dagger within the sheath, okay? So this is how you identify. Okay, next X-ray, just have a look at it and see if you can pick up some things on this X-ray. Again, this is not a test, just try to look at it and see if you can pick up some things on an X-ray. There are a couple of very obvious things, but I want you to identify as many as you can. Can you see the visceral pleura? Can you see the lung drop? How many of you saw the lung drop? Good. And more importantly, most people would not have seen this. Did you see the air fluid level? So that is, it's a simple X-ray of pneumothorax. Okay, it's a simple X-ray of pneumothorax. But if in the exam you tell me I can see an air fluid level in the right costophrenic angle, I am so happy with you. I'll jump with joy. So it's not just about the pneumothorax. Don't forget to see for evidence of air fluid level. So there is some inflammatory pathology going on. There is potentially infection setting into this patient. Okay, this could be early empyema forming into this chest. You don't know, but at least you picked up that sign. So look at this, very important. So until and unless you learn to look at a chest X-ray in its totality, you will miss a lot of signs, okay? So this is so classical, the air fluid level. I'm pretty certain 90% of you missed it. Okay, let's look at this chest X-ray. Okay, it says tension pneumothorax on the side, but spend a few minutes on it and try to pick up as many pathologies as you can. Okay, how many of you got all of this? Look at the endotracheal tube has moved to the other side. The trachea and the mediastinum has shifted to the side. More importantly, the diaphragm has moved down and there is a feeding tube there. So when I put up this X-ray, if you just tell me there is mediastinal shift and shut up, then I'm not happy. I want you to tell me more things. I want you to tell me that this patient is intubated. I want you to tell me that the tube has moved over to the right side. So this is evidence of a potentially a tension pneumothorax on the left side. This CT should never have been done. Okay, that's another question we ask you, what is wrong with this CT? And you say tension pneumothorax. But really, should this CT have been done? This guy is going to arrest. In the next 5, 10, 15 minutes, half an hour, he's going to arrest. This CT should never have been done because tension pneumothorax is a clinical diagnosis. It's mandatory that this guy should have had a good clinical examination, auscultation of the chest, and a chest tube put in, rather than sending him down for a CT scan or a chest X-ray. So this chest X-ray should never have been done. This is the problem. So in the exam, we ask you this question. Very often I ask you that what is wrong with this chest X-ray? And if you say all the findings, but you don't tell me that really tension pneumothorax is a clinical diagnosis and the tube should be put in even before you do a chest X-ray. You understand that? That's how you score in the exam, by telling me extra points. All right. Okay. Look at this one. Have a look. Spend a few seconds on it. Pick up everything that you can. How many of you picked this up? Hands on heart, how many picked this up? See this. There is atelectasis. There is loss of cardiophrenic angle. The airway is abruptly cut off. There is an abrupt cut off of the airway. And more importantly, there's a tumor there, which you can see. And as a result of which, there is a shift of the mediastinum to the right side. Can you appreciate that on this chest X-ray? Now that I've shown you, everybody will see it. But the beauty is if you can see it before I tell you, because very clearly you can see there's something going on here. And if you follow the system of looking at an X-ray, there is a definite cutoff, there is a shadow seen here, an opacity seen here, okay? And the mediastinum is moved to the right, and the left side, there's blunting of the diaphragm. Okay, all right. So these are the basics of a chest X-ray. Did it make sense?
Yes, sir.
Yes, sir. Yes, sir.
All right, now I don't want to go on and on and on about chest X-rays because I don't want to make a radiologist out of you, but just enough so that you understand that there is always more to see on a chest X-ray than what meets the eye. And the reason you are not able to see it is because you are not aware of it. I promise you, none of you would have read a textbook on chest X-rays or you know, most of you are used to seeing a chest X-ray, but nobody spent the time to understand the various features on a chest X-ray. So the eyes will only see what the mind knows. So this presentation of mine, please go back and see it again and again. It's absolutely important, okay? Somebody's raising a hand, unless it's an urgent question, let me just carry on. Because this is a very long presentation. There's lots to show you. Okay, all right. So let's look at CT scan. Is it an urgent thing? Somebody raised a hand. I don't know who it is. Oppo something or the other. Okay, carry on. So what are the principles of doing a CT scan? Okay, you've got to understand that different tissue in the body has different absorption of X-ray. That's normal. That's a common thing. If you take serial slices, then you will get multiple shots of various tissues, and the philosophy of a CT scan should be that the dose should be as low as possible. This is just a basic background. I'm just preparing you for understanding how a CT scan works. So this is how a patient lies, and this is an X-ray tube which is shooting the X-rays across here, and there is a detector on the opposite side, and this goes around in an anti-clockwise direction and takes films from all sides so that all these images are then superimposed and recomposed as a single image. Okay, first principle, simple thing, an X-ray tube, patient, and a detector. Then you have this third generation scanner where the CT scan can actually go around the patient in a beautiful way, and you can get many different sections all within seconds. So that's the second philosophy. The third philosophy is that in this part of that X-ray probe, you can either have a single row of detectors, or you can have multiple rows of it. So multiple radiations are coming from multiple areas. And at the other end, multiple detectors are present. So this is a single slice CT. One shadow of CT coming, of X-ray coming, and single row of detector. Here, there are multiple areas of CT coming, rays coming, and multiple detectors. This is called as a multi-slice CT. The advantage of this multi-slice CT is you can reduce the number of slices. You can increase the number of slices and reduce the depth between each one of them. So you can get very thin slice CT and very accurately study the anatomy of the problem. So things like a GGO, you really need a good multi-slice CT with very narrow cuts to be able to give you a good understanding of what is the pathology. So single slice CT, multi-slice CT, okay? The newer kid on the block is spiral CT. So a spiral CT continuously goes around in a spiral from top to bottom, and from bottom to top, and within seconds, you will get a full image of the whole body. So the speed of the image increases, the speed of capture is faster. So the patient doesn't have to lie for longer, and the cuts between the slices are much more thinner. So you get a much better resolution of the structures, okay? So that is a spiral CT scan. Now, CT scans are read in a unit called as Hounsfield units. Hounsfield's unit run from -1000 to +3000. These are actually white to black and all shades of gray. The human body runs between +1000 to -1000. So -1000 is air, +1000 is bone. So humans lie between this area. Water is 0. The density of water is 0. So bone lies at +1000, air lies at -1000. So this is a basic understanding of Hounsfield units. The problem is, if you put everything together on a film, you will not be able to detect, because the human eye cannot differentiate between so much variety of color. The human eye has its own limitations. It can only detect between few zones of this -1000 to +3000. So what we do is we use a zone from this side to this side. We try to keep water in the center. Just 1 second, okay? 1 minute. I will have to stop share and stop the WhatsApp because it's making noise on my ears. Sorry about that. Just 1 minute. Let me quit WhatsApp once. Okay, so the human eye can only distinguish between a small window. So you narrow the window down and you show only particular area when you want to see particular pathology. So the one that you saw before is mediastinal window. In a mediastinal window, you want to look in the midline. If I showed you all these windows together, you will not be able to differentiate between the various structures. Hence, we pick up individual ranges depending upon what is the area we want to see. So in a mediastinal window, we go from -160 to +240. So that highlights this area in the midline. If I want to look at the lung, I move the window to the right because air is black. So my window moves -1400 to +100. And that gives me a mediastinum, that gives me a lung window. Now I'm not looking at the mediastinum, I'm looking at the structures surrounding the mediastinum within the parenchyma of the lung. And then the last window that we do use in thoracic surgery is the bone window. So you move to the right, okay, completely, so move to the left. So the left will be -600 to +1400. And that will give you a good representation of the chest wall and the bony structures around there. So do you understand what is a window? What most people really do not understand what is a lung window. If I ask them to explain a lung window or a mediastinal window, they cannot explain it in terms of the Hounsfield units. So very clear cut, -1000 to +3000 is the range of the color. human eye cannot detect all of this range of color. Hence, you have to narrow the window so that the human eye can see specific structures. So you narrow it to -160 to +240, which is a mediastinal window. You then move to -1400 to +100, that is a lung window. And if you want to see the chest wall or the bony structures, then you move to the left. So the movement to the left is for bony structures. The movement to the right is for airy structures, and stay in the midline is for mediastinum. That is what is understood by 3 separate windows that we use in the chest. Okay, is this clear? So look at this picture. Here we are trying to see the mediastinum, and we have also given the patient a contrast. What you do is, it's an iodine-based contrast. You give the shot into the antecubital vein, depending upon the height and weight of the patient. The contrast will first go in the veins, so you will get the venous phase. If you wait a little longer, it will go into the arteries, so you will get an arterial phase. And if you wait a little more longer, it is called as a delayed arterial phase, when more of the distal vascular structures are highlighted by the same amount of contrast that you've given. So this is a technique to highlight the various vascular structures and the non-vascular structures. So here we are looking at it. At this moment, the pulmonary artery is highlighted, but the aorta is not. So this is a different phase of that investigation. You understand that? So we are trying to look for pulmonary embolism. We're using a different phase. When we want to look for aortic pathologies, we will just time it a bit differently. All we do is increase the time. The moment you increase the time, the arterial phase comes in later. You understand? That's the philosophy behind doing a CECT. Okay, now let's carry on. What are the different types of CTs available in the market? So you have the HRCT, which is high resolution CT. This is predominantly used to look at lung pathologies or interstitial lung diseases. It gives you a better dynamics and better, the protocol for taking the CT is designed to move onto the right side of that Hounsfield units that I showed you. So this is specifically a special type of CT which moves the whole capture to the right side of the Hounsfield units. Hence, the lung is better delineated in this. CECT is usually timed depending upon venous phase, arterial phase, delayed phase. So it depends on what structure you want to see. You time it according to that. CT angiogram, again, depends on particular areas. So if you want to see a pulmonary artery, then you will take it at about 15 seconds following the injection of the dye. So the timing is different depending upon what vessel you try to see. And then you have the low dose CT. A low dose CT is something that is used for a screening tool where the dose of the CT is dropped dramatically. You're not really looking at the mediastinum in great depth. You're looking at the lung tissue, trying to find out if there are subtle changes or early signs of lung cancer. So purely by manipulating between the Hounsfield units of +1000 to -3000, and by changing the timing of the capture within the same device, you can actually get all these CTs done. Okay. So whenever we talk about HRCT, it doesn't mean that the scanner is different. The scanner remains the same. It is just the settings are changed to see different pathologies in different parts of the lung. Okay. Did it make sense?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Yes, sir. Yes,
All
sir.
right.
Yes, sir.
So now this is the most important thing. I want to take 1 second break because I just want to get some water. So just stay with me. Give me 2 seconds. I'll get a glass of water. Okay.
Take your time.
Okay. So is it too basic or is it making sense?
It is perfect, sir.
This is better.
It's good. It's
Okay.
perfect.
Okay. All right. So now, whenever you're looking at a CT scan, imagine you're sitting on your chair, your screen is in front of you, you are running the CT scan, okay? So now look at the concept of how the scan is captured. So imagine the chest is like a loaf of bread. What the CT scan is doing is it is slicing the bread. And when you move slice by slice by slice, you are moving either from top to bottom or bottom to top. Air on a CT scan is always black. Hence, the first thing you do on a CT scan is identify the trachea, because that is the most constant structure and air is always present in the trachea. The next point is always identify bronchopulmonary anatomy. Don't look at the lungs, look at the bronchopulmonary anatomy. Try to identify the trachea as you're coming down. Identify the trachea dividing into the right and the left pulmonary, right and left main bronchus. And anytime you want to identify whether the lesion is in the upper lobe, middle lobe, or lower lobe, you never identify it on the lung. You actually follow the trachea, bronchus, and the segments. The upper lobe going up, the middle lobe coming towards you, to medially, and then the lower lobe going down. And that is how you identify which lobe of the lung this is. Never ever from looking at the lung views. You should never. The fissures can be all over the place. Things change. You can have an obscured fissure. It can be an incomplete fissure. So never ever look at the lungs. Always follow the bronchopulmonary anatomy to the segment. And that will tell you whether the lesion is in the upper lobe, middle lobe, or lower lobe. Is this clear?
Yes,
now
sir.
you are.
Yes, sir. Yes, sir. It's clear.
You're going to start with the mediastinal view. Always look at the mediastinum. Look for blood vessels and lymph nodes in the mediastinum. Look for tracheobronchial anatomy. And then look at lung windows. So always start with mediastinal windows and then look at lung windows, okay? And then you look at the chest wall. So you start in the middle and work your way outwards. That is a good method for looking at CT scans. So whenever we show you CT scans, always midline first and then move your way out to the periphery, okay? That's the next philosophy. Now, this is important. Whenever you're seeing this image of CT scan on the screen, you are standing at the foot end of the patient. The patient is lying down. You are standing at the foot end of the patient. The patient is looking up. So whatever slice that you are seeing, this side becomes the right side of the patient, not your right side. It is the right side of the patient, and this is the left side of the patient. So remember I said, this is a loaf of bread. The CT scan is slicing the loaf of bread. You are standing at the foot end of the patient. You are looking at the image from below up. It's not from above down, it's from below up. Hence, this will always be the right side. This will always be the left side. So even if the sign is not there, this will always represent the right side and this will represent the left side, unless the patient is prone. If the patient is prone, then the sides are reversed. And the only time you get a CT with a prone patient is when they're doing a needle biopsy. And you will always see the tract of the needle on that CT. But really, most of us in an exam will not keep that sort of a CT. So we will try to make it easy for you. What is on the right side and what is on the left side is what we want you to identify. Okay, is this clear? Did you get the orientation of this? How are we looking at the CT and how are we looking at the patient?
Yes,
Clear?
sir.
Yes or no?
Yes, sir.
Okay.
Yes,
good.
sir. Yes.
Now let's move
Yeah,
to
definitely.
normal anatomy. Okay. So I'm going to go from below up. Okay, just to make it sort of interesting to identify all the structures. So you can do either. You can go from top to bottom or bottom to top. It doesn't matter. But I'm just, because I want to show you a lot more anatomy, that's why I'm going below up. Okay. So first shot here, T12. Okay. I want you to look at all the structures there surrounding, and I want you to try and identify with your pen and paper. I'll give you 5, 6 seconds or 10 seconds. Please identify as many structures as you can see. Okay. Now at this section, I'm going to highlight all the structures for you to correlate. Okay. So have a look at the next image that comes through. I'm going to go back. I want you to see the T12 vertebra. I want you to see the T12 rib coming out. I want you to see the aorta. I want you to see the left gastric artery coming out. I want you to see the stomach. I want you to see the colon. I want you to see the liver. And I want you to see the pancreas. The spleen and the pancreas. Everybody with me? So far, so good?
Yes, sir.
Yes,
Yes,
sir.
sir.
We're going to
Yes,
take time on this, okay? I really don't mind taking time on this. The other thing I want you to also see is the pleural space. Can you see the recess?
Yes, sir.
Okay, good. Now we move one space, we move up, okay? We're moving this slice now. So now start identifying some structures in this area. Did you identify all the structures?
Yes.
The costodiaphragmatic recess, which I told you. Good. We move one more slice up. We're going up from below up. Look at the CT scan and see what are the structures that you can identify in this shot that I'm showing you. Normal anatomy. I want you to identify normal anatomy. Okay, look again at this. Forget this midline and everything. Identify the muscles for me. Everybody try to identify what are the muscles on the chest wall that you see. Spend a few minutes, spend a few seconds. Try to identify all the muscles that you can see in this.
Rectus abdominis, intercostal muscles, transverse abdominis.
Okay. Did you identify all the muscles? Did you identify the erector spinae, the latissimus dorsi, the intercostal muscle, the external oblique muscle, the transversus abdominis muscle, the rectus muscle, and did you actually see the superior epigastric artery? So next time you see a CT, I want you to identify all these structures because the tumor may lie here. And if you don't look at it, you'll miss it. Okay? Is it making sense? Ankit, switch off your microphone. Dr. Ankit, please switch off your microphone. This is really important. This session is going to change how you look at CTs. Please concentrate. Okay with this?
Yes, sir.
Now we move one section up. Okay, we're going to move up slowly. Look at this and try to identify some normal structures here. Look for the crus of the diaphragm, actually. In this one, I want you to see the crus of the diaphragm. Can you see it? Out here and out here. Let me just mark it for you. Can you see that? This is a T11. So you see the crus at T11. We've just gone up a little bit. stomach, and also don't forget to see the IVC. But you can't see it very well because this is not the venous face, okay? It's not so great. But still, you can see some normal structures there. Can you appreciate it?
Yes.
Charger today.
7.
Yes, sir.
Okay.
Charger.
Now we're gonna one step ahead, okay? We're gonna move a little bit more. Now start looking for some more normal structures here. Geo junction has come in. Can you see that?
Yeah.
So Laura.
The geo junction has come in, and we are now starting to see the geo junction. Guys, switch off your microphone, yeah, please. I can't keep doing this. Yeah. Please. This is very distracting. Yeah. Now I don't know how the hell to get back. It really is distracting. I mean, my rhythm goes. Okay. So this one was where you were looking at geo junction and IVC. Okay. Can you see that? Okay, I'm going to move one section up, and I want you to look behind the aorta. Can you see something coming up behind the aorta? To the sides of the two vertebrae of the vertebral body. That is azygous vein and hemiazygous vein. Making sense? One or two can switch on your microphone and speak to me. It's just the general ones I don't want. Okay. Did you see the azygous and the hemiazygous vein? So we've gone one space above. It's at T10 level. So the azygous is now coming into the picture at T10 level. We then go a little bit above, and we are now focused on the heart. Start looking at the heart. The heart is coming into the picture. I'm going to go one step behind. Here there was no heart. We're now coming into the area of the heart. Look at the heart, the low cardiac view. Try to identify what is on the right side, what is on the left side, and what is in between. Can you see that? RV and LV coming in, and more importantly, the posterior interventricular artery is coming in.
Yeah.
See that artery? You can see it very clearly. It's coming in between the heart.
PDA is coming.
Yeah. PDA is coming in.
PDA.
Now look at this shot and try to identify some more structures. Can you see the right coronary artery there? I'm going to go back to the PDA. I'm going to go one step up and show you the right coronary artery coming into view. Can you appreciate that?
Yes, sir.
The RV and the LV is better defined. The right coronary artery is coming, and behind it is the IVC. Can you appreciate the IVC? Okay.
Yes.
I move one step up, and now look at what's happening. The RCA is still there. Can you appreciate the RCA?
Yeah.
But more importantly, the RA is coming into view. The RV is still there, the LV is still there, the RA is coming into view. Can you appreciate that? And at the back, the esophagus is coming into view. And this is the point where the tip of the scapula is starting to show now. Can you appreciate the tip of the scapula? So where you see the tip of the scapula, it's usually either RCA or the PDA going into the septum. Okay? One more layer up. What is this structure at the back? Behind the azygos. It is the
Thoracic duct.
hemiazygous.
Thoracic duct. Thoracic duct.
Thoracic duct.
Hemiazygous draining into the azygous.
Okay.
Hemiazygous draining into the azygous. Next level up. Can you appreciate the 4 chambers of the heart?
Yes, sir.
Appreciate the 4 chambers of the heart. So now at this point, I will give you a clue. This is a T8 level. What you have to do, follow my marker, okay? Follow my marker. You have to draw an X like this, and you have to draw a horizontal X and a vertical X. Can you see this? This is one line, and this is another line. When you have an X, there are 4 quadrants. There's one quadrant at the top, one quadrant at the bottom, one quadrant to the right, and one quadrant to the left. Can you appreciate my line, X line? I'll show you this again later on. And
yes, sir.
Anything that is below the X line is left atrium. Anything that is above the X line is right ventricle. Anything that is to the right of the X line is left ventricle, but left of the patient. And anything that is to the right of the patient is right atrium. This is the way you identify the 4 chambers of the heart. You draw an X. 1 and 2. And then anything that's above, below. Anything that's above is RV. Anything that's below is LA. Anything that is to the left of the patient is LV. Anything that's to the right of the patient is RA. Does this make sense?
Yes, sir.
Yes, sir.
I'm just going to go back again. And one more point I want you to realize is something has come into view here. This structure has come into view. That structure is the left pulmonary vein and the right pulmonary vein. Can you appreciate that? The left pulmonary vein and the right pulmonary vein. Just bear with me when I go through these images. I know it's getting to be a bit too much for you guys, but just bear with me. This is normal anatomy. There's nothing abnormal, I'm telling you. So just bear with me. Let me finish all of these slices and then we'll talk about things more. Don't get discouraged by this. Okay, don't get discouraged. Just stay with me. We're going one more step up. Can you see the left and the right pulmonary vein?
Yes, sir.
Yeah. Yes, sir.
The left and the right pulmonary vein. I want you to identify the left and the right pulmonary vein draining into the left atrium. Remember the X, anything above the X is RV, anything below the X is left atrium. Anything to the right of the X is RA, anything to the left of the X is LV. Yeah? Okay, we go one step further now. Anything different? Can you identify some structures? At this one, I want you to identify some of the muscles. Let's move away from the heart. Look at the muscles now. And identify some of the muscles. Give it a name, okay? Give it a name. For your own self, give it a name. Every muscle, particularly at the back. Look at the back, because now the scapula has come into the being. Scapula has come in the picture. So look at some muscles which are medial to the scapula.
Rhomboids.
Can you see the serratus? Can you see, not the serratus, can you see the trapezius? Can you see the rhomboids which are medial to the scapula? And whatever is lateral to the scapula is the serratus. Is it okay so far, so good?
Yes, sir.
I will go through all of this in another session. Just stay with me. I'm going section wise just to make it easy for you to understand. Okay, we have gone slightly higher now. Okay. Can you see the right and the left bronchus coming into view?
Yeah. Yeah.
Look for the right and the left bronchus coming into view. the green bits. Yeah. And
Yes, sir.
okay, we are going a bit further up, and now the outlet has become aortic outlet in the middle. It has changed shape. The left ventricle has changed shape and it has become aortic outlet. Can you appreciate that?
Yeah.
Yes,
Can
sir.
you appreciate the right and the left main bronchus? So the left ventricle has become the aortic outlet. Now we've gone one more further step up. What is the new structure that you see here?
Pulmonary artery.
Yeah.
And above the pulmonary artery?
Ascending aorta.
The SVC is starting to come in this area. Can you see that?
Yeah.
Yes.
And of course, the anterior interventricular artery and circumflex artery. But that I don't expect you to see on this, okay? The SVC is starting to come in. That's what I want you to notice. So where I'm gone back, I've gone back again, okay? I've just gone back. Now, watch that aortic outlet, the left ventricle becoming the aorta. And then watch what is happening next to the aorta. This area. SVC. Okay? Now I'm going a bit further up. Hey, Rohit, switch off your microphone. We're going a bit further up. And something else has changed now. Can you see this?
Yeah. Bifurcation.
Yeah, is the pulmonary trunk coming in now?
Yeah.
The right PA. This is the pulmonary trunk and the right PA coming with the SVC in front of it, the two bronchi behind it. And remember, I told you the left PA lies above the left bronchus. Hence, in a second, you will see the left PA. Can you see that? Did you just appreciate that?
Yes.
Look at the pulmonary
Yes,
artery.
sir.
Just concentrate on that. Forget the RV. Concentrate on the pulmonary artery.
Yes, sir.
The right, we are coming from below up. So the right pulmonary artery has already formed. The left bronchus is here. And the left pulmonary artery is coming above the bronchus. Can you see that?
Yes.
Yes or no? Is it making sense or is it too complicated?
Yes, sir.
We're going to go one more step up. And we're going to look at the next level. Can you appreciate the SVC and the pulmonary trunk?
Yes.
Let's go one more level up and watch the two bronchus joining in the middle to form the carina. Yeah?
Yes, sir.
We're going to go one more level up and see the trachea being formed and see the aortopulmonary window below the arch of aorta. Can you appreciate that? I've got one, let me go back. This is the aortopulmonary window. Can you see this? This window here, as I go up, the aortopulmonary window is starting to form in this area. Okay? And this is N2 nodes for cancers. Arch of aorta forming. SVC remains constant. This is the azygous vein going into the SVC. Can you appreciate that? The azygous vein draining into the SVC. Now we are starting to see the arch and the arch is dividing into various structures. 3 structures, 1, 2, 3, 4, and 5 being formed. This is called as the 5 vessel view. This is the right brachiocephalic. This is the left brachiocephalic coming across to form the SVC lower down. And then 1, 2, and 3. This is the right brachiocephalic artery. This is the left common carotid artery. And this is the left subclavian artery. I'm going to go up one more section. Things are becoming more brighter. Keep focusing on that. Right and left brachiocephalic, and the 3 vessels are there. We are going one more level up. We are gradually moving up. And the RCC is forming. Okay, it's breaking. See, the right brachiocephalic is breaking into the right subclavian and the right common carotid.
If there is presence of left SBC, so there will be discontinuation of the brachiocephalic vein.
That is correct. This is the thoracic outlet view. Keep staying with me. I know it's a bit difficult to teach like this. I need a whole screen in front of me. But this is the thoracic outlet where you can see the left subclavian. You can see the left common carotid. You can see the right common carotid. You can see the right subclavian artery. And more importantly, the 2 veins, the left internal jugular and the left subclavian vein joining to form the left brachiocephalic. It's not yet joined. Lower down it joins. And here you can see the right subclavian vein and right subclavian IJV will be somewhere here. Just ahead of this will be the right IJV. Okay, very, very complex, but I tried to go slow into each one of this to make you understand what is present at these levels. Did it make sense what I just did? Hello?
Yes.
Yes, sir.
Yes, sir.
Yes, Prof.
Okay, now I'm going to show you the 5 levels that are of importance. Now, the whole thing is difficult to explain on an online class, but I'll just show you the 5 levels that are important, okay? So understand this. This is the thoracic inlet level. When you read a CT, you must read a CT at these levels. So thoracic inlet level, you must identify what is the left subclavian vein, what is the left IJV, the left common carotid, the left subclavian artery, the right common carotid, the right subclavian artery, and the right subclavian vein, and the right IJV will be in this slot vein. So that's the first level called as the thoracic inlet level. You must identify 1, 2, 3, 4, 5, 6, 7, 8 vessels in this area. The next one is called as the 5 vessel level, which is lower down. We are going reverse now, from the top to the bottom. The next one is called as a 5 vessel level. So 2 veins and 3 arteries. The next one is aortic arch level, where you see only the SVC. The next one is the aortopulmonary vessel, where you see the ascending aorta, descending aorta, the carina, the SVC, and to the right is the aortopulmonary window, where you get station 5 lymph nodes. The next one is a high cardiac level, where you have to draw your X, and when you draw your X, what lies above the X is RV, what lies below the X is LA, what lies to the left of the X is left ventricle, and what lies to the right of the X is RA. And at the same point, you've got to look for superior and inferior pulmonary veins. And also at that point, you will also see accessory hemiazygos draining into the azygous system on the right side. And then this is the X that I was talking about. Can you see that X? Very clearly differentiates the 4 groups of the muscles. And then you go further down, and that is called as a low cardiac level. And in the low cardiac level, you're looking for the PDA and the IVC. Okay, and the esophagus. You can see the esophagus. So these are the 5 levels you must know in an exam. It is mandatory. I will normal anatomy at 5 levels. Low cardiac, high cardiac, aortopulmonary, aortic arch, 5 vessels, and thoracic inlet. Okay, thoracic inlet, 5 vessels: aortic arch, aortopulmonary, high cardiac, and low cardiac. Okay. Does this make sense now? I'm sorry it is very, very prolonged, but I have to go slow to explain everything. Is everybody with me or everybody is lost?
Yes, sir, we are with you. Thank you.
Yeah, we are
Yes,
with
sir.
Are you with me
Yes,
so
sir.
far so good? Did it make sense? The
Yes, sir.
periphery is okay.
Yes.
It is the center that you
started
need. The
with
mediastinum is difficult to understand
99 and all
for
of
a lot
you.
of people. Most people struggle with mediastinum. So we've still got 99 people on the group, so that's good. We must be doing something right. Okay. So let's look at the next
100 on YouTube.
imaging. MRI. Again, a lot of people don't know how an MRI looks like, okay? Or in fact, they know how an MRI looks. They don't understand the philosophy behind an MRI. So there is something called as hydrogen atoms in the body. The whole body is made up of hydrogen atoms, okay? We all know that. And every hydrogen atom is actually moving in this circular movement. It has got a frequency called as Larmore's frequency, okay? So it moves between this, it just moves like this, a circular movement. The hydrogen atom has a shaky movement and it moves. What the MRI principle is that a hydrogen atom is called as a proton because it's got a plus sign to it, okay? Every time you apply a magnetic field to the proton shifts to align itself to the strong magnetic field, okay? So the proton is moving by itself, and the moment the magnetic field comes in, the proton moves to align itself to the magnetic field. That is normal reaction. Any magnet moves to align itself to north-south pole of the bigger magnet, okay? So a fringe magnet has 0.001 Tesla. The MRI machine has 1.5 Tesla. So look at the difference between the power of the magnet that you're applying to the body. So when you apply this RF energy with the magnet, the proton absorbs it and then releases it and aligns itself to the magnetic field. And this shift of alignment of the proton is interpreted by the camera or by the machine. And each proton, whether it is in the fluid, whether it is in the epithelium, whether it is in the muscle, they all shift to a different levels. So the difference in the shift is recreated as a dot matrix on an image, and then the whole image is recreated to show you the anatomy in great depth. So this is how you are. Your protons are moving left, right, left, right. The moment you apply a strong magnet, all the protons align themselves to this magnet. And the shift from the y-axis or the x-axis to z-axis is what is interpreted by the machine. So look at it, these are all out of phase. They're all moving at their own sweet time in life. And the moment you apply an RF pulse or a magnet, then they all, the out of phase, go in phase. And the moment they go in phase, the alignment is changed in this axis. And it is this change in alignment that is picked up by the machine, and that gets represented as an image. It gets calculated and then gets changed into an image. Okay, so it's very simple concept. H1 ions, apply magnet, shift of H1 ions, that shift is equal to a dot on a screen. And each shift of dots, multiple thousands of shifts of dots, get reconstructed into an image. Now, there are two types of things that you've got to remember whenever you see MRI images. One is called as a T1 phase, T1 image, and one is called as a T2 image. Whenever the magnet is applied parallel to the H1, H plus ions, it forms a T1 image. And when it is applied perpendicular to that same H plus ion, it forms what is called as a T2 image. Just very, very, very basics. We are not radiologists. We are not going to do an exam in radiology. I just want you to understand the basic concept of what is T1 and what is T2. And really, this is what is it. It's the difference in color from white to black, depending upon which is the tissue. So T1 has more of fat and blood in the white zone, whereas T2 has more fluid in the white zones. It's just as simple as that. I don't want to go into more details because there are actually 6 phases of imaging in an MRI. So just understand the philosophy, understand what is T1 and what is T2 weighted image. So what are the indications for an MRI? Indications are when you're dealing with lung cancer, if you're worried about vascular invasion, if you're worried about neural invasion, you want to look for tumor resectability. So you do an MRI, gives you a very good concept of what is happening, particularly around a blood vessel. It's very good for T-staging of a lung cancer, takes away a lot of overlay from the CT. So you might use it sometimes, particularly when you're dealing with mesothelioma, you might actually want to exactly stage the T-stage of the lung cancer, T-stage of the pleural cancer. It's very good for spinal involvement of neurogenic tumors, particularly for dumbbell tumors. At the back, you want to know whether the tumor is going into the vertebral canal or not. And it's great for follow-up of thymic hyperplasia or less than 1 centimeter thymic nodules. You do not want to operate on every single thymic nodule. So when you have a myasthenic or a non-myasthenic patient with a small thymic nodule, the next year, if you don't want to operate, then next year you can repeat an MRI. An MRI is very sensitive, much more sensitive than a CT scan for thymus. So it is indicated in that situation. Also used in pregnant ladies or people with iodine allergies. So in pregnant, because you're using magnet rather than radiation and X-rays, they are better tolerated. It is not carcinogenic to the fetus. So that's why these are the indications of MRI in thoracic surgery. There are certain contraindications. Pacemaker dependent rhythm is a problem. Any pacemaker is a problem because a metal object in the body is not a good idea, and it will actually really disturb the magnet because you're really going into a very strong magnetic field. So anything with metal in it is not a good idea. So any aneurysmal clips, cochlear implants, and things like that, not a good idea. Relative contraindication is, of course, claustrophobia and certain surgical metalworks, and first 3 months of pregnancy. In fact, surgical metalwork comes in absolute contraindication rather than relative contraindication. So look at this. This is how the images are formed. You can see a tumor being seen here. So this is a T1 versus a T2 image and showing you the difference in the densities of the 2 images. So it is used to calibrate whether is it a cyst, is it a tumor, is it going into the nerve vessels and things like that. So I'm not going to go into greater detail about MRI because really none of us are going to sit there and try to analyze MRIs. But works very well for thoracic outlet. I think I forgot to mention that thoracic outlet is the main indication in my clinical practice for doing an MRI. If you really want to see angiography, MR angiography of the thoracic outlet is fantastic, particularly when you're looking for subclavian artery stenosis or thoracic outlet obstructions. So MR works very well. Thymic hyperplasia, again, a good indication for use of MR. Okay, very, very basic. I don't want to go into too much detail about MRIs. Okay, are you with me?
Yes, sir. Yes, sir.
Yes, sir.
Yes,
Enough
sir.
for the exam. This is enough for the exam. This is a surgical exam. You're not supposed to know details of an MRI in the chest. Okay, let's look quickly at positron tomography. So I'm still doing normal stuff with you. I don't want to do abnormal stuff first before you understand all the normal investigations. So principle of PET is 18 FDG emits protons. They clash with the electrons in the tissue, and the pair of photons that are reflected back by the tissue are detected by the scanner. Okay, and so you use a few CT and a PET scanner. So first you do a CT and then you do a PET scan, and both the images are superimposed on each other to understand what exactly is happening. We always talk of the brightness in terms of SUV, standard uptake value, and anything more than 2.5, you start wondering whether is it a positive PET or not. Okay, higher the number, more is the positivity of the PET. Staging of lung cancer or any cancer for that matter. And nowadays it's part of the NICE guidelines. You cannot do any therapeutic intervention without a PET scan. mesothelioma, thymic tumors, neuroendocrine tumors. In neuroendocrine tumors, particularly, it's not the 18 FDG PET which works. You have to do a special special type of PET called as DOTA PET, D-O-T-A. Okay, and DOTA is an acronym of that dye. It's a special isotope, and it specifically goes and attaches itself to the receptors on neuroendocrine tumors. So whenever you're dealing with carcinoid tumors in the exam, whenever I ask you, should you do a PET, you must say, I will ask for a DOTA PET. Okay, so it's very important to understand the difference between FDG PET and DOTA PET. It's different. Infection, rheumatoid nodules, organizing pneumonia, vasculitis, all of this can give you a false positive on the PET. Okay, false negatives is high blood glucose, small tumors, low-grade tumors, particularly adenocarcinoma. I've said this before as well. Almost 15 to 20% of adenocarcinomas are PET negative, and it's very, very important to be aware. And you should not say that a PET negative lesion is not a cancer. You have to biopsy it. Same thing works with carcinoids also. On an 18 FTG PET, the carcinoid may be negative, whereas it will come positive on a DOTA PET. So you must remember these things. Ground glass nodules, we spoke about it earlier, and neuroendocrine tumors, you must always do DOTA PET. That's the important thing that you have to do. Sensitivity and specificity, it's a lot of different publications, but ESTS, CRS guidelines and ACCP guidelines also speak of it. The range is huge, but pretty sensitive, very good. If it comes positive, is the negativity that's the problem. Specificity is pretty low. So if you don't see it on a PET, doesn't mean that it is not cancer. And if you see it on a PET, there is more metabolic activity, but histology has to prove the presence of a cancer. So it picks up the lesion, but it cannot tell you whether it is cancer or inflammation. Okay. Other images available for us are 3D reconstructions of the chest wall. We can do that for trauma, for fractures and things like that. These softwares are excellent tool in radiology, and everybody must use it, including the 3D reconstruction of the blood vessels that are available. Digital subtraction angiography is when you put in the normal CT versus the contrast CT. One is superimposed on the other, and all the things which don't have contrast in it are cut away. So you do what is called as a subtraction angiography, so that the blood vessels are highlighted. And so this is a digital subtraction angiography. This is a computer software which does it for you. So you take the protocol is different for different vessels, and then A upon B, A minus B is equal to C, which is the image you're seeing in front of you. Okay. For CTPE, I told you there's a different protocol. You have to use different timings of capture to look for pathologies within the pulmonary artery, things like aneurysms and things like embolus. You must look not just at the arterial phase, you must also look at the venous phase. You will get different pathologies which will get picked up by these technologies. And MR is very, very good for angiography. MR gives you an excellent reproduction of an angiography. Only problem is MR takes a very long time, and many thoracic pathologies, the patient may not be able to lie down for 40-45 minutes for the MR acquisition. So that's the problem with doing MR. 3D reconstruction works very well when you're talking about chest wall diseases, particularly as a preface for 3D printing. So whenever we want to 3D print a prosthesis on the chest wall, we always start with normal CT. We would then do a 3D reconstruction. The 3D reconstruction is then sent to the software, the CAM, the 3D CAM, and then that will actually identify the whole thing. You've got to measure it, and that will then get sent to a printer, and the printer will print out the prosthesis that you want. So 3D reconstruction is quite a good tool for 3D printing, and more of it will be used now in the future. Virtual bronchoscopy is an excellent tool, really gives you a good idea of endobronchial lesions even before you put in a bronchoscope. So just on a CT scan, you have the option of recreating it. It is a very good tool we use in EMN quite a lot, electromagnetic navigational bronchoscopy, where we recreate the airway and recreate the pathway to the tool. So here you are, here's the correlation, here's the tumor. And even before you've gone in with bronchoscopy, you know exactly which segment to look for. And using that, you put in and your biopsy yield goes up. There is some papers which are talking about this increase in the yield of bronchoscopic biopsy secondary to use of virtual bronchoscopy. Okay. All right. Everybody okay with this?
Yes, sir.
Yes, sir.
Okay. Now we have two options. One is that I take you through these pathologies and you just identify the pathology, identify how to look for it, or we do this on another day. I'm perfectly happy. If it's become too long, it's already 2 hours since we've been talking. If you guys want to take a break or you want to just call it a day, I'm perfectly all right. Because I've got at least a collection of 100 different snapshots. These are not full CTs. I've tried not to keep full CTs. But if you want to continue, I'm quite happy. We can take a break for 5 minutes and continue. Is that what you want, or do you want to just call it a day? There's too much to take on board. I completely understand that. Quick response.
Another day.
Okay.
Another day.
Yes,
All
sir,
right.
another
I'm
day.
okay with that.
Another day, sir. Another day.
Everybody said another day. Okay. Now, was it a bit too much? Did I go into too much detail?
No.
Did I confuse you more?
It was
It
absolutely
was
fine.
perfect.
It was
Let me
adequate.
just stop the recording. Let me stop the recording. And now let me stop sharing. I want some feedback from you guys. Did this make sense, what I told you?
Absolutely.
Absolutely,
Yes, sir.
sir.
Absolutely, sir.
Absolutely.
Absolutely.
The reason why I took so much time to spend at each section is it is absolutely vital to know normal anatomy. You cannot do abnormal anatomy till you know normal anatomy. It's absolutely vital. I'll take some questions if you guys want. Anybody's got any pressing?
What? Hello. Hello, Sushilpa.
Yeah, 1 minute, Shilpa. See, the most problem when you go for these clinics is everybody assumes that you know normal. And they start showing you abnormal CTs and abnormal pathologies. But that's not the way to learn. The way to learn is to know what is normal. The moment you know normal, the abnormal stands out. It stares you in the face. Okay? All right, Shilpa, we'll take your question.
So I'm a little confused in the
1 minute,
thoracic.
do you want me to continue recording or shall I just pause this recording? It's okay, it is normal.
We can pause it,
I
sir.
have already paused it.
Yeah.
Okay, tell me.
So I'm a little confused in the thoracic inlet level, the 8 vessels. I just
I will send you the picture, Shilpa.
Yeah.
Send you the picture with the names on it.
Thank you.
See, Shilpa, you got to remember there are 4 veins and 4 arteries.
Yeah.
So this is very easy. It's not difficult. Once you just think about it a little bit, with the picture in front of you, you will understand. It's right subclavian vein, right internal jugular vein. You know that.
Yes.
On the left side is left subclavian vein and left internal jugular. Okay.
So it was.
And there are only 4 arteries. One is the right common carotid and right subclavian artery on the right, and on the left side is left subclavian and left common carotid. It's actually not difficult. It's just that when you look at it all together in one area, you get a bit confused. But if you use just a basic knowledge of anatomy, you will get it. There is 4 veins and 4 arteries. It's as simple as that.
Sir,
sorry, I missed subclavian.
No, that's all right. Don't worry.
Vikas here, sir.
Yeah, Vikas, tell me. I love your headgear.
Today the internet is very unstable, so I had to put it.
Sign of absolute frustration. You've thrown it over your head. What the hell is Dr. Khan talking about?
No, no, sir. Today the internet is very lousy, so I'm not getting breaking. Sir, tomorrow when you start, can we have few images where you describe different levels of nodes?
Again, I will.
In the CT.
Nodes?
In the CT.
Okay.
Yes, sir.
I'll do the nodes, yeah.
Yes, sir. Yes, sir.
Okay.
So, this is Abha.
And it is a request to the house before coming to the session tomorrow, if everyone goes through today's videos, it will be very fruitful.
Please do it. Please do it. It's
Yes.
very important. Normal anatomy is absolutely mandatory, guys.
Yeah.
So
I can
I
see
had a
some
question.
chat
So
session.
this is Abha.
1 minute, 1 minute,
Sure.
One minute, Abha, wait. Let me just read through some. Hello, sir. It would be really helpful if you could help us identify the different lobes of the lung on a CT based on bronchus and fissure. Okay. Next time I'll do that. It is Faisal is saying it's an extraordinary class, which more than a direct interaction. Okay. All right. Thank you, Dr. Faisal. Where does one see for azygous lobe? Samir, I did not deliberately show an azygous lobe. You look for it on the right upper lobe next to the SVC. I can show it to you. I have got images of azygous lobe, but I didn't want to confuse you. That's why I didn't show it just as yet. Okay, sir, you take mediastinal windows step by step. What about lung windows? Yeah, we haven't done lung windows yet. Just hang on.
Yeah.
Lung windows are easy. If you know chest X-ray, then lung window is easy. Not a problem. Mediastinum is the one that's more difficult. Okay, lung windows are quite easy. All you have to do is follow the bronchus. But if you want, I'll do that as well. I've got to moderate it so that it just works. Arif, thank you. Where does one see for azygous lobe? Best lecture in radiology. Thank you, Murali. Okay. Microphone switch off, please, Andre. Okay. Thank you. Dr. Zakir from Bangladesh. Hi, we got that. Okay, so let's take some questions. Abba, you were there. Come in.
Good evening, sir. Sir,
Good evening.
I just wanted to know the difference between a CECT and a CT angio. So angio, you said that you can be doing it in a venous phase, arterial phase, a delayed arterial phase. What about a CECT? How is the difference?
Same. And angio is actually just a difference in the timing. It's just like a normal CT, but the volume, when you're doing an angiogram, the volume of the contrast goes up dramatically. You change the volume and you change the timing. So it's exactly the same investigation, but the protocol changes. So you have to give a larger volume and you got to time it in a different way.
So in a CECT, you give a larger volume, is it?
No. In an angio, you give a larger volume.
In an angio, you give a larger volume, right? Thank you so much.
Because you want to more specifically highlight the blood vessels. So you want the contrast to last for longer within the circulation. So you give a higher volume in an angio.
Right. Thank you, sir.
Did it make sense?
Yes, sir, it did. Thank you, sir.
Yeah, Shashikaran, come in.
Yes, sir. Sir, I just wanted to know how to see for the rotation on the X-ray. You told us about the points, but it was. I know it is a very basic question, but
to measure the distance.
No. It's very important. What you have to look for is the clavicle, the medial borders of the two clavicles, and you got to make sure that they are equidistant from the vertebra because that shadow is there. And the second thing is you got to look at the trachea.
Okay.
Trachea has to be in the midline. If it is rotated, then the trachea will move either to the right or left. But of course, if there's a pathology, that changes the position of the trachea. That's why you need more than one views to understand whether this is rotated or not. The clavicle is a fairly fixed, constant point. And as long as the clavicle is equally distant from the trachea on the side and the vertebra at the back, you're centralized.
Okay.
Next.
Hello.
There's somebody else. Yeah.
Hello.
Who's that?
Yeah, this is Sandeep.
Yeah, Sandeep. Tell me.
Yeah, how do you measure the length and breadth of a lesion on a CT scan?
How do you measure? There are tools available. There are two different ways of measuring, 2 or 3 different ways of measuring a lesion on a CT scan. I actually discussed this in the last class. There is you have tools available on the scanner on your console, which will help you to get vertical and horizontal diameters. But that is not the one that is used, particularly when you're dealing with solitary pulmonary nodules. What you use is volumetric analysis. So you do a volumetric assessment of the volume of the tumor rather than the size of the tumor. like it was pointed out, that a 1 centimeter tumor doubling time doesn't mean it becomes 2 centimeters.
Okay.
It means 1 centimeter can become 1.2 centimeters, but the volume has doubled. You understand that? So
Yeah.
really the assessment is on volumetric analysis, and there is a formula which converts diameters into volumetric analysis.
Okay.
It's all done by the computer, and it's on the screen. You don't have to worry. You just have to make sure that you're measuring the diameters accurately, and you've got to take the longest diameter and the longest horizontal and longest vertical diameters.
Okay.
Next question is Sudhir Mishra. Did you want to ask something? Sudhir doesn't want to ask. Anybody else?
Thank you.
Dr. Zakir Hussain, did you want to ask anything?
Yes, sir. Assalamu alaikum.
Walaikum assalam, Zakir Hussain.
I am from Bangladesh.
Speaking to your microphone, I can't hear you.
Hello.
Yeah, speak up, speak up.
Hello.
I can't hear you, Zakir. Hello. Zakir, just work on your microphone. Let me get and shake Arif.
Okay, can I ask a question?
Who is that? Yeah, Dr. Zakir, you're back on. Speak loudly into your microphone.
Yes, sir. Assalamu alaikum.
Alaikum assalam.
Sir, I want to know that is there anything regarding distance? I think I want to know 2 to 3 millimeter distance in HRCT, but in CT scan or contrast NS CT scan 5 millimeter or 7 millimeter distance. Is there anything like this?
Yeah, it complete. See, the reason why I'm not mentioning the sections that you take is it depends on the quality of the CT scanner that you have in your institution. So you know, HRCT is a much wider section as CECT is much wider section as compared to HRCT. But I don't want you to look at the thickness of the sections. I want you to understand what it is used for. So CECT is used more for the mediastinum, and HRCT is used more for the interstitial of the lung, parenchyma of the lung. So that's why I don't want to use the words what is the thickness of the section, because your machine may not give me the same thickness as my machine does. So this is always a constantly changing factor. Hence, we do not try to talk in terms of thickness.
Thank you, sir. My another question regarding HRCT. Is there anything to use contrast in HRCT?
No, preferably if you are going into the world of contrast, then go into CECT.
Thank you, sir.
It's more or less the same machine that you use. It's not a different machine. But if you're going to do contrast, see, there are technicalities which a radiologist will tell you all these things. For a surgeon and for the lay person, I think it's enough to know that HRCT is for parenchyma, CECT is for the midline. If you want to go from HRCT to contrast, then it's better to go into CECT domain rather than HRCT. HRCT usually, as an understanding of a layperson, HRCT is usually non-contrast. But there are some HRCT studies, particularly when they're looking at bronchiectasis and they're looking at sarcoidosis and these subtle changes in IPF or in lung transplant scenarios, they may do these things. But those are radiologist domains rather than my domain, to be honest.
With your kind permission, can I?
Thank you, sir.
Okay, thanks, Dr. Zakir. Who's next?
With your kind permission, can I have some?
Can I ask a question, sir?
Yeah, who is that?
I'm Futun, sir. Yeah. Sir, sorry if you have already discussed it because I got disconnected. If you have already discussed it, just ignore my question. For the lateral chest X-ray, you mentioned how the technique, how it is being done right and left. But like if someone gives you a lateral chest X-ray without label, would you be able to differentiate is it right or left?
Well, ideally, they should not give you a chest X-ray without labels. That is not allowed. Okay. By law, you are supposed to look at the identifiers on a chest X-ray. They may blank out the name of the patient, but they have to keep the identifiers. So it is actually very, very poor practice to see a chest X-ray Because if there are no identifiers, then you don't know whether you're holding it the correct side up or the wrong side up. Do you know what I mean? If you move it left to right, it will look as if the patient is looking to the right. I know the question you're asking me. Most people will tell you that if he's looking to your left, it is a right lateral, and if it's to your right, it's a left lateral. But
No,
that
I
is
don't know
not
that
the way
either.
to identify. That's not the way to identify. Because if by mistake you turn it around and there are no identifiers on it, there is no way you will know which lateral it is. You have to have identifiers. That's mandatory.
Okay, thank you. And if you can, I think someone else also asked for it. If you can in the next session to elaborate more on how we can identify the lobes and the region in which lobe, that will be great.
Yeah,
Thank you.
Will do, not a problem. Thanks. Who's that?
Khalil, my question.
Sorry, who's that?
Dr.
I can't see.
Jibril Khalil.
Dr. Jibril Khalil, yeah, come in.
Yes, sir. So my question is, I think I want to get it very clear. The staging of lung cancers. You said MRI might be better in staging for lung cancers.
It's not a usual thing. MRI is not used as a tool for lung cancer staging. It is not in the recommended guidelines for MRI for lung cancer.
Okay.
If you're following guidelines, then MRI is not part of. It's only when you're doing a very complex resection with SVC involvement, then I would do an MRI because I want to know vascular invasion. But if you look at the guidelines of lung cancer investigations, MRI is not part of the recommendation.
Okay. Thank you very much.
All right, thanks. Next question, please. Sandeep, iPad, are you finished? Who is Oppo A37FW? Put your name, yaar. At least we know who we are talking to. Who is Oppo A37FW? Okay, no, you put the hand down. Okay, so are we happy? Everything is done. I'm very sorry. Today's lecture is a very complex thing.
Oh, it's really good.
Normal anatomy without being in front of you. When I'm in front of you with the screen, it's so easy to explain, but trying to do it remotely takes a lot more effort.
Someone has written in the comments, sir. It is the best radiology lecture in past 20 years. I can vouch it is the best in next coming 20 years also, sir. Definitely, no doubt about it.
Definitely, sir. Definitely, no doubt about it.
Oh
my God, he's a master. Confused. I thought you would get too confused. That's why I was trying to go really slow.
No. Oh God.
Shilpa, I can see you're in Derriford, aren't you? Are you in the hospital?
What? Yeah, I am in the hospital. I'm 24 hours. 24 hours on call.
you know that is the place where I trained. And I started from Derriford, so I owe everything to Derriford.
Yeah.
And Jonathan and Answat White, two of my mentors.
Yeah.
Okay. All right, guys. Thank you very much. I hope it was.
Thank you, sir.
Thank you very much.
Thank you very much, sir.
Thank you so much, sir. Thank you.
The next session, actually, I gave away yesterday because I told Hiremat that you guys wanted to have a one-to-one with me for the FRCS exams, the exam going earlier in the day, we were talking about it. So I told Hiremat that I probably may not be doing a talk, but let me see. If he has not given away the 9:30 slot, India 9:30 slot, I'll do the rest of this lecture tomorrow. Okay?
Thank you, sir.
So did the exam going guys want to just talk to me or not? Because I promise you there is a different way. I was reading the WhatsApp and
Majority of people are exam going, but
yeah, I was reading the WhatsApp and you guys are sharing all these things with each other. But it's great. I mean, I'm very happy that you're sharing things with each other. But exams are not passed on this basis. Exam is passed here in the brain. It's in the thought process. Exams are passed only on thought process, I promise you. It's only a technique. All of you have the knowledge. I have absolutely no doubt in my mind that all of you have the knowledge. What you lack is the technique. What you don't understand is how should I put this knowledge into practice? And all of you are sitting here talking with me, doing this discussion. The question is, how many of you have got buddies with whom you are discussing every day a clinical case? That is the key. See, when I got together for the exam, three of us got together, Naren Murjani, me and Theo Velisaris, and every day after 5 o'clock, after 6 o'clock, we used to spend quizzing each other and presenting a case. And we used to catch any Tom, Dick and Harry, Betty, Mary Lou, anybody. We would just catch them and present the case to them. Because really, it's all about talking. Until and unless you learn to talk, you cannot pass this exam. You cannot reproduce in the MCQ. Because if you have not, the outpatients and the inpatients are the best place of knowledge. You don't need any textbooks. You really don't need any textbooks. Of course, you have to read the basics. I'm not denying that. But don't go for the big ones. Just go for simple things. 2 textbooks in thoracic surgery. One is Naren Murjani's Key Topics, and the second one is the ESTS textbook. If you have it, you use it. But if you know the key topics inside out, the same thing for cardiac. If you know the key topics inside out, and for pediatric cardiac, if you know the key topics, you will pass this exam. I mean, I passed this exam on key topics. I'm telling you. I'm declaring it to you that I passed this whole exam on key topics, not on textbooks. You cannot recollect from textbooks.
It's not
I'll tell you one thing. I knew the key topics inside out, first page to the last page. Every single page, I knew it. And that is the way to pass this exam. You have to keep talking and keep reproducing it. And you have got to write it down. Until and unless you write it down, you will never be able to reproduce. That's why I ask you to get a 200-page notebook. Draw a diagram. Draw a diagram. That is the key to learning. You can read, Shields or all these big books. Nothing will go in. Absolutely nothing will go in. And everybody who's doing FRCS has already become old. You are no longer medical students. So the neurons are starting to die away. So you better understand that Shields is not going to work. You need only the small books. I'm very concerned that you guys are not being guided adequately. That's why I need to talk to all the exam going people.
That will be great if you can do that. Yeah.
Okay, all right. Okay. Anything else? Any more questions, pressing issues? People over it?
So I think.
Who's that? Shilpa.
So I think you're you're a very good teacher. So I believe whatever you teach directly goes to the head, inside the brain. So why don't you teach some cardiac techniques?
I can actually teach you cardiac. To be really honest,
we are just grabbing you completely.
No, honestly, Shilpa, I'm actually very switched on with the cardiac things. I'll tell you, it's not difficult. Cardiac is 10 times easier than thoracic. My problem is if I don't finish thoracic, then I'm not doing it justice. If I start focusing on cardiac topics now, and the other thing is I don't want people to feel upset that, he's trying to take over cardiac. So I can teach you cardiac, but let me finish thoracic first. If I finish all the thoracic topics, I will then... Nobody can explain an IABP.
I'm jealous.
Than me, I promise you.
Your thoracic has started making sense after you started teaching it.
Good, Amma.
Jealous. No. I'm jealous. All these cardiac people are benefiting from you, but we want to benefit from lacking in cardiac. I want benefit of cardiac.
We are all one big family. We are all part of the same family. We have got a pediatric cardiac surgeon sitting in the room for God's sake. Dr. Faisal Hussain is there. He's sitting in the room listening to chest X-ray and CT scan. Come on, Silpa.
I'm doing every second.
So see, we've got a pediatric, and he's a senior guy. He's not junior. He's not a resident. He's a senior consultant in Dhaka. He's sitting.
We want topics. Then we want topics actually on talks.
There is no cardiac, no thoracic. Okay, we are cardiothoracic, one family. Okay, but I'm happy that we are making a difference. I'm very happy that everybody is gotten up, and the cardiac boys have also gotten up, and we are now having more and more teaching. This pandemic is a blessing in disguise, guys. I promise you. Okay, so but don't forget to thank the first 5 guys. Okay, the 4 of them and Nikhil. They are the ones who started, and Manjunath who pushed me. Manjunath also pushed me this time, saying, "Sir, why don't you teach?" Okay, so you guys need to thank them.
No, sir, we should thank you, sir.
Thank you. Thank you very much.
Okay, good night, sir.
Thank you.
Good night, sir. Thank you, sir. Thank you so much.